This conference will now be recorded.
All right, chapter 36, patients with special challenges. So, patients with special challenges. This is something we're seeing a lot more, especially if you work more in the city stuff as well. Homelessness, homeless camps, things like that. I dealt with a lot of this over the years, working in the bigger cities like Manchester, Nashua, Somersworth, even working down in the greater Boston area. A lot of homeless people that are out there, and it's definitely a special challenge. A lot of them just they don't have the insurances and things like that, and they kind of wait until like the very end until they're really, really sick. Then they call 911 instead of getting preventative maintenance done and checkups. They just wait until the very end at that point, which makes things a little more difficult for us. I get a lot of those when I'm working down in Winthrop, Mass, when we go to Mutual Aid to Revere as well, and it's just there's a lot there. Other ones would be like patients with poverty. We all know the areas we respond to. The biggest thing is don't judge and treat every person the same the best we possibly can. Bariatrics, we live in New England, and technology-dependent people as well. Let's see, we'll go to the wrong button. Way too fast. Hospice and terminally ill patients. These can be challenging patients to deal with because a lot of them that are terminally ill are on comfort measures. Even if they're really sick, they don't get transported. Tracheostomy care dysfunctions, home care patients as well, and then looking at sensory deficit loss, developmentally disabled patients. Excuse me, and trauma. 1 second. Sorry about that. My nose is getting a little sucked up in a minute. All right, looking at trauma as well, applying the fundamental knowledge to provide emergency basic care. Get the right button. So looking at some of the patients, trauma patients that have special considerations, cognitively impaired patients. So we look at recognition and management of trauma patients in the pregnant patient, the pediatric, the geriatric, and also looking at the pediatric, pregnant, and geriatric patient as well, looking at pathophysiologies. We're going to kind of cover a bunch of this stuff throughout this lecture today. So today, more people have chronic diseases that live at home or outside of the hospital setting. So a lot of people, they don't want to die at the hospital, right? No one wants that to happen. So they all choose to go back home and they go on different types of comfort measures, hospice care, and things like that, because they don't want to just have their last days in an unfamiliar place in a hospital being waited on by nursing staff. They want to be home with their family. So we're starting to see a lot more of that. And the same thing with dialysis. It's no different with that as well. We're seeing more at-home dialysis care. People are bringing machines to homes to have dialysis done in their homes. So we're going to look at focusing on a decrease in the length of hospitalization. And one of the biggest programs of this on decreasing the length of hospitalization, obviously, is quick care. But we're seeing shorter hospital stays and then discharge to home, and then community paramedicine is kicking in. Where the hospitals employ paramedics or private ambulance services, or even municipalities, where they have paramedics going around to homes just to do follow-up care with these patients that are being discharged from the hospital. And why is this in effect? Well, one of the biggest things of this is if a hospital discharges a patient to go home and they have to get readmitted back to the hospital based on symptoms getting worse from the discharge diagnosis, the hospital has to eat the cost because they discharged too early. This is where community paramedicine comes into place. We're starting to see patients get more treatment at home through telemedicine. As you can see, improvements in medicine and technology. Medicine has been every day. There's something new that comes out. Technology, every day there's something new that comes out with some kind of treatment plan or anything that can help diagnose and treat patients. And you see it all the time on TV. If you're watching any kind of TV, or even if you're watching, like, let's say Hulu, Netflix, whatever, and they have ads, you'll see big pharmacy coming out, putting out ads of these new medications that are out there that are showing you this what's new and upcoming to treat certain diseases. Patients with special challenges, patients with diseases resulting in altered body functions, patients with sensory deficits, and then geriatric patients that have the chronic diseases as well. So we're going to kind of go in depth a little bit more on infants and small children that have congenital heart disease, patients with neurological diseases, patients with congenital or acquired disease resulting in altered body function that requires medical assistance for breathing, eating, urination, bowel function. So you may have patients that have Foley catheters in place. They might self-cath at home that causes more infection, things like that. To patients that have ileostomy and colostomy bags, so that they can defecate into these bags and remove waste product. So there's a lot of things that happen outside of our, I don't want to say normal, because no matter what, people are still normal, but dealing with these different challenges. Some patients depend on mechanical ventilation, intravenous pumps, and other devices at home. Patients that are chronically on vents. And yes, that's an EMT scope of practice, taking a patient on a ventilator, as long as they're not intubated, if they have a trach in place on a ventilator, that is perfectly within your scope of practice at the national level and in New Hampshire protocol to take that patient to a hospital, because the patient or the family members can address the vent if there's problems. So don't be distracted by the equipment. You're going to have patients on different wound vacs, ventilators, pumps, feeding pumps, everything else. And that's okay. That's all within the scope of practice to be able to transport these patients in a 911 setting. Now, patients that are doing in a facility, that's a different story. Then things become a little more complicated and require a high level of care. But in a 911 setting, we're not going to require you to have a paramedic respond to this because they might not be readily available. We can't say, well, we're not going to take you. So we're starting to see more of that. Don't be distracted by the equipment. Again, focus on the patient. Focus on airway, breathing, circulation. If the emergency is a result of mechanical failure, use the equipment on the ambulance or the family's go bag. A lot of times if they have issues with this kind of stuff, they're going to have a go bag with it. Other devices would be like left ventricular assist devices, or something called an LVAD. So there's a bunch of different things that are out there that you could come in contact with. So intellectual disability, like a developmental disability, refers to insufficient development of the brain, resulting in some level of dysfunction or impairment. This can include intellectual, hearing, or vision impairments that surface during infanthood or childhood. Intellectual disability resulting in the ability to learn and socially adapt at the normal developmental rate, right? So we have patients that might have high functioning autism, or what used to be called Asperger's, or if they're just autistic. So we may have run-ins or patients that have Down syndrome. We're going to see these different challenges, and it's going to present to us differently, and how we're going to treat is going to be completely different as well. To the point you may have to have family assist you with a lot of this stuff. Some possible causes also be congenital infections, genetic factors, complications at birth, malnutrition, environmental factors, prenatal drug or alcohol abuse, traumatic brain injuries with TBIs, poisoning with lead or other types of toxins. So again, when we're doing our assessments and we have a pediatric patient, a lot of times I'll ask, I shouldn't say pediatric, more towards the infant side, I'll say, was pre and postnatal care done effectively? Did they seek prenatal care? Were they taking prenatal vitamins? What was being done prior to the delivery? And then sometimes they'll say, well, we had no care done at all, because they probably can't afford it. Or we get the ones that said, oh, my stomach hurts, abdominal pain, significant abdominal pain, they're going into contractions, they deliver a baby and go, I didn't even know I was pregnant. And that does happen. They had no idea. So some characteristics of a patient with slight intellectual impairment may appear to be slow to understand or have a limited vocabulary. Now, we want to sound smart when we show up, right? We're EMS providers, brand new EMTs, you're learning a bunch of different vocabulary, different terms, and terminology and everything else that's out there. If we use these big words on patients that do not have the intellectual sense of what we're doing, they have intellectual impairment, they may not understand what you are saying. So I'm not saying get to their level. Don't speak like a physician. Speak like a normal human being talking to somebody else. Instead of using the word abdominal pain, do you have any stomach pain? Things like that. Do you have any pain retroperitoneal? What does that even mean, right? Well, obviously, we know that means, but they have no idea. Does your back hurt at all? And if it does, if I push here, does it hurt even more? And we're pushing where the kidneys are located, right? That'd be retroperitoneal area. So again, we stop using those big words. We get back down to the layperson vocabulary to kind of assist with that. They may behave immaturely compared to their peers. If severely disabled, they may not have the ability to care for themselves, communicate, understand, or respond to surroundings. Right? So you're going to have to explain exactly what you're doing to these patients at all times. You cannot just start doing stuff. They need to be educated on what's going on. Right? That's why if you ever work shifts with me you'll notice that I try to talk my way through stuff to these patients. So Nick, I'm going to pick on you for a minute. All right. When you had that critical call with me, okay, and we had that patient in severe respiratory distress, you jumped on board, okay?
Yeah.
You hear me explaining everything in detail what I was doing to the patient?
Yeah, it was awesome.
Okay. And it wasn't just for you because you were new, okay? It's because that's what's going on, right?
Mm-hmm.
That's
Yeah.
why
I think it actually calmed the patient down considerably too. He felt like he was part of the process.
right. So what if I had just taken that mask on a ventilator and I put this mask on this guy's face without talking to him? What do you think could have happened to him?
Yeah, I totally would have freaked him out. Definitely.
And the last thing we want is to have a guy who's in congestive heart failure with acute pulmonary edema to take that mask off and he's freaking out. So I'm not saying that he had an impairment or disability, but just communicating with them and explaining what was going on made a 90% difference what happened to that patient because he allowed me to do things. Now take a normal patient with no disability, now add a disability to that. We got to really explain and go slow and no fast movements on these patients. Right? I can't speak that enough. You guys really, really need to slow down with patients that have intellectual changes to help them understand what is going on. We're going to rely on the patients and family members for information to understand how well the patient can understand you. What is their normal? How do they communicate? All right. If they're deaf and you do not know American Sign Language, what's another way we can communicate with them?
Writing.
What was that?
Writing.
Yeah, writing things down. Okay. Let me ask you this. Do all your ambulances that are out there, do you guys carry whiteboards and dry erase markers so you can have a conversation back and forth?
I just found out one of our ambulances, I thought they were shades to close a window, but
Yeah.
they're actually whiteboards.
Right. So if you have a whiteboard as a shade for a window, can you take that board down and hand it to the patient so they can write stuff down to you?
No.
Okay. So this are some of the things. People that have disabilities, are you prepared to handle the disabilities in the back of the ambulance? Some ambulances have gone as far as making autism kits. Okay, making a kit for autistic children so then when they have a patient, they can take them out and they can use the toys and different things to help communicate. So there are methods that are out there. The question is how progressive of a service are you guys going to be? So patients may become more difficult to interact with as anxiety increases. We've got to keep anxiety down. High anxiety is bad for patients. It increases heart rate, increases blood pressure. It also can increase respiratory rate. A patient that's already sick starts becoming anxious can make things a lot worse. Also, anxiety may also be hiding pulmonary embolus as well. Make every effort to respect the patient's wishes and concerns. If they don't want you to touch them, then don't force yourself upon them. Unless they are altered and they don't make the right decisions based on their alteration that they have in mental status, then you would think a conscious, alert, and oriented person would say, yes, I would want the help. Then you provide the care. Okay. Utilize family to help you with this. Take as much time as necessary to explain in a calming, understandable way the treatment the patient is about to receive. Like I said, Sean kind of heard me do some of this on our critical trauma patient the other day. Obviously, Nick saw me do this with our critical respiratory patient. You have to take the time to explain what you are doing, right? So Sean, the guy that we had the other day, okay, he was petrified of narcotics, wasn't he?
What's that?
So the guy we had the other day, the trauma patient,
Yep.
I had to explain to him about fentanyl because he was terrified about it because all they hear about in the real world is fentanyl kills people, right?
Oh, right. Yeah, he was saying, don't give me too much. Like, isn't that bad for you and stuff like that?
Yep. So I had to take the time to explain to him the dose I'm giving you is not a lethal dose. It's enough to treat your pain. So again, I had to go through that process because the media has destroyed this for us. Right? People don't want fentanyl anymore because, oh my God, they overdosed on fentanyl, they died. That's because they took a gram of fentanyl. That's what kills them, you know? But 100 mics is not going to hurt somebody. So these are things you got to think about. All right, a little more in depth there, but good things to understand. All right, so autism spectrum disorder. General term used to describe a group of complex disorders of the brain development that vary greatly in signs and symptoms. So pervasive development disorder characterized by impairment of social interaction. Right. So other characteristics we're going to as well would be severe behavioral problems, repetitive motor activities, impairment in verbal and nonverbal skills, and may be hyper or hyposensitive to sensory stimuli. And may also may show their pain in unusual ways, such as humming, singing, or removing clothing. You got to be able to pick up on these. So understanding that autism or the autistic spectrum that we deal with, we really need to pay close attention to these other behaviors, all right, and to be able to treat these patients. Right, so there's a wide spectrum of disability. Some patients are independent, others are unable to even care for themselves. And then we have the high functioning as well, which used to be called Asperger's, but they're really getting away from that name, just calling them high functioning autism. Patients have difficulty using or understanding nonverbal means of communication, so frequently will have the difficulty making eye-to-eye contact. They do best with simple one-step directions. They could be 40 years old with autism. You have to revert back to them being 5. Step-by-step, simple instructions. And tend to have trouble answering open-ended questions, so ask them simple, closed-ended questions. Not open, closed. Do you have any chest pain? Or does your chest hurt? Yes or no. Are you having trouble breathing? Yes or no. Do you feel weak? Yes or no. Keep it simple, to the point, looking for that yes or no answer. Close-ended questions, nothing that they can go on and on and on about. Now, if they're high-functioning autism, maybe you can have a full conversation with them. I know some of my friends that I have that work in the EMS field that are currently paramedics and firefighters have high-functioning autism, and they're perfectly fine. Other things, they may talk in a robotic or monotone speech pattern. They may repeat phrases over and over again. They may confuse pronouns. And they may say like the word like you versus what they really mean is I. They may not speak at all. Approximately 1 in 68 children is diagnosed with autism. 1 in 68. It affects males 5 times more than females and typically diagnosed by age 3. Children with autism also receive special instructions and care in a school-based setting as well. Sometimes they don't even like being touched. So having them put on certain devices like the pulse oximeter, having them put on a blood pressure cuff or helping you with a blood pressure cuff, having someone they trust do it as well. Utilize your surroundings, utilize your resources that you have. Older adults may not even be diagnosed because, again, autism has never really been diagnosed or received any assistance in some of the older adults because really they really didn't know much about it. Patients with autism generally do not have other medical disorders and will have medical needs similar to their peers without autism. We're going to rely on the parents or caregivers for information. And we're also going to keep them involved in the patient's treatment. They need to know what's going on. Rely on the parents or caregivers for information and keep them in. Make sure we keep them involved. Make sure they know what's going on. If they're in the back of the ambulance, please do not just start throwing procedures at them. A lot of times, someone with autism, especially at the younger age, may look at their mother or father to say, yes, it's okay. It's okay to do this. Move slowly. Fast movements can cause patients with autism to freak out. Stay calm. Perform a physical examination from distal to proximal. We talked about this with pediatrics, right? Toe-to-head assessment. It's the same thing. All right. We're going to demonstrate and examine on the parent or caregiver first to show the patient what he or she can expect. All right. So you may have to say, do you mind if I demonstrate on your mom and dad? Okay. They're like, yeah, they might be okay with that. All right. Any questions on autism at all? Good. Anybody else wants to add or any experiences? Because this is kind of important stuff to talk about.
So just to clarify, Kevin, so it is no longer referred to as Asperger's, though. It's high functioning autism.
That's what I've been told in some of the readings that I've done. Asperger's is still out there, but we look at high functioning autism.
Okay, good. Yeah, that's good to know. Thank you.
Any other questions or comments or other calls you guys have had and want to share an experience?
I have I mean, when I was ski patrolling, we had a call regarding probably an 11-year-old boy who was autistic, and it was very difficult to do an assessment because he was, verbally, it was just different. So we really relied on his adult. Once we found his adult, to help us determine if this was a normal level of consciousness or if it was altered.
Yeah, very tough. And for the record, everybody, I do know how to use a chat box if you guys want to put stuff in there too.
Are you sure you didn't minimize it too much?
No, it's there. It's there. I just kind of put it to the side. So I try to look for things that pop up. All right, let's talk about Down syndrome. So characterized by a genetic chromosomal defect that can occur during fetal development, resulting in a mild to severe intellectual impairment. And they can actually test for this while a baby's still in womb, right? While woman's still pregnant, they can stick a long needle and pull certain fluids out. And I'm drawing a blank of what it's called. I can't think of it. There's a name for it. And if anybody knows it, shout it out, please. I just can't think of what it's called, but when they pull that out and they do a test, I can't think of what it is.
I almost said gene therapy, but I don't think it's gene therapy.
No. There's another name for it. Thank you. Amniocentesis, it's called. Thanks, Tandra. Also, increased maternal age and family history are known risk factors for this condition. So the older you are as a female while get pregnant, and they say increased maternal age, they say after the age of 40, have a higher chance of your baby having Down syndrome. Doesn't mean it's going to happen, but there's a higher chance of it happening as well. So increased maternal age or family history. So associated physical abnormalities and conditions with people with Down syndrome have a round head with a flat occiput in the back, enlarged protruding tongue, slanted wide set eyes and folded skin on either side of the nose, covering the inner corners of the eye. short, wide hands, small face and features, congenital heart defects, thyroid problems, hearing and vision problems, misalignment of teeth and other dental anomalies, speech abnormalities, and epilepsy as well. Why should I hit the B button? All right. Increased risk for medical complications as well. So as many as 40% have heart conditions and hearing and vision problems. I had a 17-year-old that had a DNR because she had Down syndrome. At 17. Intubation for paramedics would be difficult due to the large tongues in the small oral and nasal cavities. Mask ventilations can also be challenging. Jaw thrust maneuver or a nasopharyngeal airway may be necessary for this. So you may have to put in an NPA as well. Management of seizures is the same for any other patient with seizures as we discussed in chapter 17 under neurological emergencies. And approximately 15% of people with Down syndrome, the downaxial joints, where the first two vertebrae meet, is unstable. So they call adaxial instability, which is called AAI, where most patients do not show symptoms for this as well, and increased risk of complications when they experience any kind of trauma. So just kind of keep an eye on that. Patient interaction. It is normal to feel somewhat uncomfortable when initiating contact with developmentally disabled patient, but again, they're still human. They're still people. So treat them the same way, but you may have to make some alterations in your assessment, right? Treat the patient as you would any other. Approach the patient in a calm, friendly manner, watching for signs of increased anxiety or fear. We do that even with patients that are not autistic, that are not have Down syndrome. Just us coming in with a bunch of bags and tools and everything else can build up someone's anxiety. So just calm, friendly, introduce yourself, right? And go with your assessment. Have the members of your team hold back slightly until you can establish a good rapport with the patient. Do not overwhelm these patients with multiple people coming in, right? Come in one or two, have other people hold back, and just start your assessment. And then more people can be introduced. Introduce your team members and explain what they are going to do. I'm going to have my partner, my friend here is going to take your blood pressure. Don't introduce them as your partner. Say my friend, okay? Because they understand what friends are. Move slowly but deliberately. Explain beforehand what you are doing, just like you would with any other patient. Watch carefully for signs of fear or reluctance from the patient. You also want to make sure that you are at the same eye level, so don't hover over them, right? Don't scare the patient. Get down to the same level as they are. If anything, get a little bit lower if you can. Do your best to soothe the patient's anxiety and discomfort as you work through your assessment and provide treatment. By initially establishing trust and communication, you'll have a much better chance for a successful outcome. You've got to make sure you establish that good communication and trust when you walk through. All right, brain injuries. So patients with a prior brain injury may be difficult to assess and treat. So they call it traumatic TBI. So take the time to speak to the patient and the family to establish what is considered normal for the patient. You have to know what's normal, right? Now, for the people that have been riding in action, you guys responded over to the Neuro Restoration Center yet in Freedom? Anybody gone over there yet?
No, we didn't.
No. Okay. So there is a neuro center that's in Freedom that we go to quite often, right? Where patients have traumatic brain injuries. Green Mountain Treatment Center in Effingham used to be Lakeview Neuro Rehab Center, right? About 10 years ago, that was Lakeview. And that's where everybody went that had TBIs that stayed there, right? Do not expect the patient to walk or to the ambulance or stretcher. A lot of times they're bed confined, right? And if they're not going to walk outside. A lot of times they're wheelchair bound. So don't expect someone to get up and walk. Treat the patient with respect, use his or her name, explain procedures, and reassure the patient throughout the process. It's no different than we talked about with every other patient contact we have. If you touch a patient without their consent, if you start doing stuff without their consent, that's assault and battery. You have to explain it. You have to get permission to do things. Don't just automatically assume. Visual impairment, sensory disabilities. Causes could be a congenital defect, disease, injury, degeneration of the eyeball optic nerve or nerve pathway, causing that visual impairment. So the degree of visual impairment may range from partial to total. Some patients lose peripheral and central vision, and some can distinguish light from dark or discern general shapes. Visual impairments may also be difficult to recognize as well. So look for signs that the patient is visually impaired. Look for glasses. Someone has a cane, a service animal. When you do pupillary assessment, if they're kind of glossed over, ask them, do you have glaucoma? Are you blind in that eye? All right. So you can see these kind of things just by looking at their eyeballs, looking at their pupils, looking at the eye itself. Then ask them that question. Make yourself known where you are when you enter the room, especially people that can't see. Let them know. Hi, my name is Kevin. I'm here at the ambulance today. We're coming through your front door. We're going to make our way over to see you. Introduce yourself. That helps calm the patient. It also allows them to the patient to identify their voices and locations as well. Retrieve any visual aids and give them to your patient to make the interaction more comfortable. We do not carry anything in the ambulance that is Braille. I have not seen that. Maybe long time ago. Not anymore. We just don't carry stuff that has Braille. So you have to explain everything to them. A visually impaired patient may also feel vulnerable, especially during the chaos of a crash scene because they don't know what's going on. How about this? How about you get let's say a 30-year-old female patient who's blind that has chest pain. Now we have to put a 12 lead on, right? We have to explain to a blind female that we're going to take off her shirt, go underneath her breasts and lift her breasts up if they're large, and place electrodes underneath the left breast. We have to explain that to them. They can't see what we look like, what we're doing. They have to trust us. So you have to make sure that you give them the reason. Don't give them reason not to trust you. The patient may have learned to use other senses such as hearing, touch, and smell to compensate for the loss of sight, and the sounds and smells of the scene may be disorientating. Tell the patient what is happening, identify noises, and describe the situation and surroundings, especially if you must move the patient. If they can't see and you got to carry them down a flight of stairs, let them know you're putting them in a chair and not to reach out, that you're not going to drop them. Remember, they're used to being independent and doing things on their own based off different senses, and you're taking that stuff away from them. The patient may use a cane or walker, so be sure to take it with you in the ambulance. Don't say, well, we're not putting it in the back of our trunk, there's no room. Make room for it. They need these. Service animals can remain with the patient and will provide reassurance for the patient and prevent delays in transport. However, in some cases, you may need to make arrangements for the care and the company of the animal as well. So what to think about with this? We can take service animals in the back of an ambulance. That's perfectly fine. There's no law against that. An ambulatory patient may be led by a light touch on the arm or elbow, or the patient may rest his or her hand on your shoulder. It's okay, let them do that. You may ask the patient which method they prefer to use. Patients should also be gently guided, but never pulled or pushed. Remember, they have to be able to trust that they're walking in the right direction. And also, obstacles need to be communicated in advance. If you bring a first-in bag in with you, or you move something, that's another thing too as well, being on a scene of patients that are visually impaired. Do not start rearranging their furniture. It's set up a certain way, they have it memorized. If you move things on them, they're going to try to get up trying to find it, and they're going to get hurt. Okay, so put everything, if you have to move a couch, put it back to where it was, okay? Same thing with a chair, tables, remote controls, it doesn't matter, telephones. Keep things where they normally leave them. If not, they're not gonna be able to find them. All right, so hearing impaired. Impairment can range from slight hearing loss to total deafness. So patients may have a difficulty with pitch, volume, and also speaking distinctly. So patients may also learn to speak even though they have never heard sounds as well. Patients that have may have since sustained partial or total hearing loss, leading them to speak too loudly. You'll see this a lot with older people that have some degree of hearing loss. Some common forms of hearing loss would be sensorial deafness, nerve damage, or results from a lesion or a damage to the inner ear. Conductive hearing loss caused by a faulty transmission of sound waves. And this can be caused by an accumulation of wax within the ear canal or a perforated eardrum as well. With some clues that a person could be hearing impaired, or presence of hearing aids, poor pronunciation of words, or failure to respond to your presence or questions. Right, so bring the hearing aids with you, okay? Make sure the patient has them. Let's see, did we lose somebody? Right. So communication with hearing impaired patients. Assist the patient with finding and inserting any hearing aids that are there. Help them put them in. Face the patient while you're communicating with them. Please do not go behind them. Do not exaggerate your lip movements or look away. Let them read your lips. Position yourself approximately 18 inches directly in front of the patient. Right. Let them be able to read your lips and be able to have decent communication that way. Do not speak louder or try lowering the pitch of your voice. Just speak normal. Most people who are hearing impaired have learned to use body language like hand gestures and lip reading. Ask the patient, how would you like me to communicate with you? Right? American Sign Language, I don't know it. If any of you do, congratulations. It's awesome you guys learned that. It's not something I ever had to learn in school or anything else. So you may need to have an interpreter, family member, or a friend come with you. If an interpreter is not readily available, call your receiving facility early to request one. They have people available to do interpretations, right? And it can even be done through video conference, right? So telemedicine is a phenomenal thing. Helpful hints for communication. Speak slowly and distinctly into a less impaired ear, or position yourself on that side. Change speakers to someone with a lower pitched voice. So change your provider. Provide paper and a pencil so the patient may write down your questions, and the patients may write answer with response as well. Only one person should ask interview questions to avoid any confusing of the patient. Avoid confusion, please. One person at a time. Try the reverse stethoscope technique. Put the earpiece of your stethoscope in the patient's ear and speak softly into the diaphragm of the stethoscope. It might help them hear better as well. So here are some American Sign Language related to illness or injury. The first one, A, is sick. B, the middle one here, is hurt. And this one here is help. Looking at A, B, and C here. So hearing aids make sound louder. Remember, so again, if they have hearing aids in, please do not yell at the patient. Right? They probably can hear perfectly fine with hearing aids in place. Maybe either external or internal, and there are several types, like behind the ear, contained in a plastic case that rests behind the ear. Conventional body type, older styles used for profound hearing loss, and then in the canal and completely in the canal type. So they're contained in a plastic case that fits partly or completely inside of the ear canal. The in-the-ear type contained to the shell that fits in the outer part of the ear, Implantable options are also available, like cochlear devices. This device should fit snug. If you are whistling, the hearing aid may not be in far enough if you hear the whistle. If the hearing aid is not working, troubleshoot the problem. Try to help them. The next picture here is going to show you some different hearing aids that are out there. If you remember, these are very expensive, so if you do decide to take them out, which you might have to get a body temperature, then just, again, just be careful with them. They need these to hear. All right, CP, or cerebral palsy, is a group of disorders characterized by poorly controlled body movement. Some causes would be result in damage to the developing fetal brain while in utero, oxygen deprivation at birth, traumatic brain injury at birth, or infection such as meningitis early childhood may cause cerebral palsy. These symptoms range from mild to severe, like poor posture, uncontrolled spastic movements of the limbs, visual and hearing loss or impairments, difficulty communicating, epilepsy or seizures, intellectual disabilities, unsteady gait, which is called ataxia, which may necessitate wheelchair or walkers, as you can see in the photo up here. So some considerations would be observe the airway. Patient may have an increased secretion production and difficulty swallowing, which is called dysphagia. It may require aggressive suctioning to clear the airway. So again, you may have to suction quite often. Other important considerations: do not assume the patients have an intellectual disability. They may not. Limbs are often underdeveloped and are prone to injury as well. And patients who have the ability to walk may have an ataxic or unsteady gait and are prone to fall. So if the patient has a specially made pillow or chair, the patient may prefer to use that during transport as well. Pat the patient to ensure his or her comfort. Never force a patient's extremities in any position. You can actually do fractures and actually hurt them more. Whenever possible, take walkers, wheelchairs along during the transport. You can take a folding wheelchair in the back of an ambulance. What you cannot do is take an electric wheelchair. Be prepared for seizures and keep suction available to protect that airway. All right, this is spina bifida. Spina bifida is a birth defect caused by incomplete closure of the spinal column during the embryonic or fetal development, where the spinal cord is now exposed. The opening can be closed surgically, but often leaves spinal or neurological damage. Some associated symptoms would be hydrocephalus, which requires a shunt. And this requires the placement of a shunt to drain the excessive amounts of cerebrospinal fluid from the brain. So partial or full paralysis of lower extremities, loss of bowel or bladder control as well, or extreme latex allergy. So ask the patients and caregivers when you're doing this, how to best move them before you transport them. How are we going to move these patients? And a lot of times the family and our staff at home would understand like the best way to move them from that position. Paralysis is the inability to voluntarily move one or more body parts. Causes could be stroke, trauma, or birth defects. The patient may have normal sensation or, excuse me, or increased sensitivity. Hyperesthesia. So facial paralysis may also be cause communication challenges as well. And the diaphragm may also not function correctly, requiring the use of a ventilator for paralysis patients. Some specialized equipment you may run into will be urinary catheters, tracheostomy tubes, colostomy feed bags, or ileostomy bags, and different feeding tubes. The patients may have difficulty swallowing as well, creating the need for suctioning. So you just got to pay attention to your patient presentation. So each type of spinal cord paralysis requires its own equipment and may also have its own complications. So talk to caregivers to kind of find out what's really going on with the patient and what their normal is and how they move patients around. They would know the best, the caregivers as well. Always take great care when lifting patients and moving paralyzed patients. Remember, they have no control. All right, so bariatric patients. So obesity is a condition in which a person has an excessive amount of body fat, the result of an imbalance between calories consumed and calories used. Causes of obesity are not fully understood, may be attributed to low metabolic rate or a genetic predisposition as well. The term obese is used when someone is 30% or more over his ideal body weight. What's it called? Versus, well, we'll stick with that. His or her ideal body weight. Severe obesity is when a person is 2 to 3 times over their ideal weight. I've never been a big fan of this whole ideal weight thing. So that could be a different discussion another day. All right, quality of life may be negatively affected, associated with mobility difficulties, diabetes, hypertension, heart disease, and stroke. So interactions with patients with obesity, patients may be embarrassed by their condition or fear of scorn as a result of past experiences. Right? Remember, we're there to help everybody, no judgment. If a transport is necessary, plan early for extra help and or specialized equipment, like bariatric stretchers, to hover mats, to hover jacks to help lift. Right? The last thing we want to do, even though they're overweight, we do not want to hurt ourselves in the process. Right? Send a member of your team to find the easiest and safest exit. These do not make things more challenging than they have to be. Do not risk dropping the patient or injuring a team member by trying to lift too much weight. Okay, if they're too much weight, ask for more help. Interaction with the patients with morbid obesity, treat them with dignity and respect. Ask your patient how is the best to move him or her before attempting to do so. What is the best way for you to get out? Avoid lifting the patient by one limb, which could risk injury or to an overtaxed joint. We do not want to lift patients by one limb. Underneath the arms, lift them up. Avoid lifting, coordinate and communicate all moves to all team members prior to starting a lift. On 3, we're going to lift. 1, 2, 3, lift. We do it all together as a team. If the move becomes uncontrolled at any point, stop, reposition, and then resume. Please do not try to put yourself in a position that you're going to hurt your back. Look for pinch or pressure points from equipment because this could also cause significant soft tissue injury or a deep vein thrombosis. Larger patients may have the difficulty breathing also if you lie them down or supine. It's what they call positional asphyxia. Laying on their stomach, laying on their back because their chest wall is so heavy that it can't move or can't breathe for them. So there are many types of specialized equipment that are out there for morbidly obese patients. In some areas have specialty equipment, bariatric ambulances for this such. So New Hampshire, every county got a cache of equipment for bariatrics, and it was placed in one fire department so they could respond out if needed, or you could utilize their equipment. Right. So like Laconia Fire, they have one for their county. Conway Fire has one for Carroll. So again, they're out there. You just got to know who has them and how do you obtain getting that such equipment if needed. All right, trach tubes. Patients with medical technology assistance. That's where your trach tubes will come into play. Tracheostomas provide a path between the surface of the neck and the trachea. They get placed in. I'll show you a picture that's in the next slide. So a stoma is kept open by a plastic tracheostomy tube. This can either be temporary or permanent. This passes from the neck directly into the major airways. Very important, this does not get clogged. For patients who depend on home automatic ventilators or have chronic pulmonary medical conditions. And this tube bypasses the nose and the mouth. I'll show you the tube here. So it's almost like an intubation tube, but smaller. Same thing, a balloon cuff so it doesn't come back out. These are prone to obstruction by mucus or foreign bodies. This is an emergency event. They have to be suctioned out. Right? You got to clean these out. So we looked at something called the DOPE mnemonic. It's no different than patients that are on ventilators. DOPE stands for displacement, dislodgement, or damaged tube. So basically, dislodge, displacement, obstruction of the tube, pneumothorax, and equipment failure, like a kink tube, ventilator malfunction, or an empty oxygen supply. If you go through this and there's equipment failure, then disconnect the vent, put on a bag valve mask, and breathe for them. Common problems may be bleeding or air leaking around the tube. The tube can become loose or dislodged, or the opener on the tube may become infected. So you're going to look for the redness and infection, any kind of pus, infection, redness, swelling, and take note of that. As far as management, maintain an open airway. Suction the tube if necessary to clear any kind of mucus plug. Stand clear if they start coughing, because that stuff shoots out like you wouldn't believe. Right? So make sure you stand clear of the cough, because they can put mucus all over your face, mouth, nose, uniform shirt, all that kind of stuff. Maintain a position of comfort for the patient, provide transport to the hospital, administer oxygen. Mechanical ventilators, possible causes for use. Congenital defect, chronic lung disease, TBI, muscular dystrophy, or a disease process that weakens the ability to breathe and requires a permanent tracheostomy and a mechanical vent. If the ventilator malfunctions, remove the patient from the vent, apply a tracheostomy collar, which is designed to cover the tracheostomy hole and has a strap that goes around the neck. It may not be available in the pre-hospital setting, so a lot of times they have them at their homes. It can be improvised by placing a face mask over the stoma as well. And if they require assistance ventilation throughout transport, then ventilate them if their oxygen levels are dropping or they're having a hard time breathing. This is a transport vent. Okay, nothing like we carry for interfacility transport. This is something the caregivers would have at home. We're not going to change the settings on it. If it doesn't work, take it off, use a bag valve mask. All right, let's see. Apnea monitors used for infants who are premature and have severe gastroesophageal reflux. They have a family history of sudden infant death syndrome or SIDS, or have experienced an apparent life-threatening event. They call ALTE. So apnea monitors are used for 2 weeks to 2 months after birth to monitor the respiratory system. It monitors sounds and alarm if the infant experiences bradycardia or apnea, so they stop breathing or their heart rate goes down too low. This is attached with electrodes or a belt around the infant's chest or stomach to help with the monitor. The attached electrodes kind of go on the chest. They monitor the heartbeat. We'll provide a pulse oximeter reading that will assist you in assessing the patient's respiratory status. And if possible, bring the apnea monitor to the receiving hospital with the patient because it can track what was going on. And it can bring up the rhythm that was actually there. Internal cardiac pacemakers. Pacemaker, so we'll get that here in a second. So, which is a device implanted under the patient's skin to regulate the heart rate. Heart rate goes too fast, it can kick in and slow it down. If it goes too slow, it can kick in and make it go faster, back to a normal rate. Typically placed on the non-dominant side of the patient's chest, or for smaller or extremely thin patients in the abdomen. Pacemakers may also include an automated implanted cardioverter or defibrillator to monitor the heart rhythm as well. Another name for that would be an AICD as well. Never place the defibrillator paddles or pacing patches. So basically the pads of that directly over an implanted device. We're going to gather information about the cardiac pacer while you obtain a patient's history. I'm going to cover that here in a second. Some patients will have a pacemaker identification card in their wallets containing information about the device as well. There are different types of pacers that are out there. There's either continuous or they're on demand. Continuous means that it's just continuously being paced. The on-demand ones only kick in when the heart rate goes too high or too slow. You want to make sure that you ask your patient, what kind of pacemaker do you have? All right, LVADs, or a left ventricular assist device, is a special piece of medical equipment that takes over the function of one or both of the heart ventricles. They can have RVADs, LVADs, or BiVADs, right, left, or both. Typically used as a bridge to heart transplantation while a donor heart is being located. This may be a permanent solution for patients who do not qualify for transplant as well. These patients here, if they're having an LVAD issue with the actual device, need to go to the place that put it in. And one of the biggest places that plants them is Tufts Medical Center in Boston. Now, we're not going to transport a patient down that far from up here. They'll go to a local hospital and they'll be transferred out. Use a caregiver as a resource for these. Provide support measures at basic care, right? It may be difficult to palpate a pulse because there's two different types. There's what they call pulsatile and non-pulsatile. Pulsatile, obviously you'll feel a pulse. The non-pulsatile have an impeller inside, an impeller that spins, pushing blood through. Therefore, you're not going to be able to feel a beat. What you will hear is a humming sound, and you want to make sure you hear that humming sound inside based on revolutions per minute. Be prepared to provide CPR. The one thing you want to make sure you do before providing CPR is contact medical control. Right? That's going to be very, very important to contact them because a lot of LVADs, you can't do CPR, you'll actually dislodge it. The external defibrillator vest is a vest with a built-in monitoring electrodes and defibrillation pads worn by the patient under his or her clothing. This is attached to a monitor that provides alerts and delivers a shock. So if the patient is in cardiac arrest, the vest should remain in place while you do CPR. We don't want to take it off. Central venous catheters. A catheter that has its tip placed in the vena cava, providing venous access. You may see this for at-home care, like long-term antibiotic drug therapy or pain management or chemotherapy. Other ones you'd see is nodal parenteral nutrition, or called TPN, hemodialysis. And the location of these would be the chest, upper arm, or subclavicular area, as you can see in here. This is a triple lumen catheter. If these get ripped out, you need to apply extreme pressure to these because patients can bleed out very quickly. Right? Even as paramedics, we do not access these in a 911 setting. So common problems are broken lines, infection around the lines. Keep in mind, if an infection happens around the line in these, it's a direct access to your heart. So they call it a central line. They can also be clotted. So a lot of times what they'll do is they'll put heparin inside the line itself, so that way there it doesn't clot up. Or bleeding around the line from the tubing to the attached line itself. Gastrostomy tubes are placed into the stomach sometimes referred to as a gastric tube or a G tube. These are placed into the stomach for patients who cannot ingest fluid, food, or medication by mouth. It may be inserted through the nose or mouth into the stomach as well using a nasal or orogastric tube. These may be placed surgically directly into the stomach through the abdominal wall. I'll show you guys here, as you can see in this photo. This is a G tube for a child. So if they become dislodged during the patient's normal daily activity, immediately stop any flow of any fluids, assess for bleeding into the stomach. What you'll probably see is like nausea, vague abdominal discomfort, vomiting. If you see this, especially coffee ground emesis, and they have internal bleeding, or blood in emesis as well, blood in the vomit. Patients may also have an increased risk for aspiration with these as well. So always have suction readily available. Patients with difficulty breathing should be transported in a sitting or lying on their right side with head elevated 30 degrees. Diabetic patients who receive insulin and gastric tube feedings may become hypoglycemic quickly. So you want to make sure you're checking repeat sugars. Unless the tube is dysfunctional or dislodged or partially dislodged, continue the tube feeding and transport the pump with you. All right. So shunts are for patients with chronic neurologic conditions. These are tubes that drain excess cerebral spinal fluid during assessment. You want to make sure that you feel the device beneath the skin on the side of the head or behind the ear. What you'll have is a fluid reservoir, and this should alert you to the possibility that the patient has an underlying shunt. So just take a look and see what they have. Feel for it. All right, so there's other types called a ventricular peritoneum shunt, which drains the excess fluid from the ventricles of the brain into the peritoneum of the abdomen, or the ventricular atrium shunt, where it drains excess fluid from the ventricles of the brain right into the right atrium of the heart. So a blocked or an infected shunt changes the mental status. Respiratory arrest may happen with this, and infections may also occur within the first 2 months after insertion. Signs of distress would be a high-pitched cry or a bulging fontanelle in infants, headache, projectile vomiting, altered mental status, irritability, fever, and nausea. You may also have difficulty with coordination or walking, blurred vision, seizures, redness along the shunt tract, bradycardia, or heart dysrhythmia. All right. Vagus nerve stimulators are treatments used for seizures that are not controlled with medication. So to stimulate the vagus nerve at predetermined intervals to prevent seizure activity. So these are used in children older than 12, which are located under the patient's skin about the size of a silver dollar. If you encounter a patient with this device, contact medical control and follow your local protocols to see if you can activate it to make it so the patient stops seizing. Usually it's done with a magnet to kind of help with that for the activation. Colostomies, ileostomies, and urostomies. Colostomy and ileostomy is a surgical procedure that creates an opening between the small or large intestines and the surface of the body, which allows for elimination of waste products into a clear external bag or pouch, which is emptied or changed frequently. Please do not break these bags off in the back of an ambulance, right? They smell horrible, and their stomach contents can get all over the ambulance. Treat it with care. Bags that are over full or over pressurized will pop. And if it pops, it goes everywhere. What a mess does it make? Right? So if possible, if they're not having any issues, have them change it before we start transporting. Now, common issues with ileostomy, colostomy bags, and everything else. They can become blocked based upon certain foods they eat, one of them being peanuts, because they don't digest very well. They can cause major blockage for the bag itself. So we're going to assess for signs and symptoms of dehydration. If the patient has been complaining of diarrhea or vomiting. Area around the stoma is also prone to infection. So we're going to look for signs of infection by redness, warm skin around the stoma, and tenderness with palpation over the colostomy or ileostomy site. So you want to palpate it, take a look at it, look and see if there's any spread of infection. So you can see that redness in the skin kind of growing. Urostomy is a surgical procedure that connects the urinary system to the surface of the skin, which allows urine to drain through a stoma in the abdominal wall instead of through the urethra or a urinary catheter. So contact medical control to follow local protocols of care for a patient with any one of these. Normally, they're going to get transported to the hospital. We're not going to be changing out these bags in the back of an ambulance, and they're going to take care of it there. It's not very hard to change them, but again, if it's not done right and it's not in a sterile environment, it could become infected. All right, so interaction with caregivers is an important part of our patient assessment process, right? They have become experts in caring for the patient, so they determine the patient's normal baseline before assessment. Ask, what is different today? Home caregivers are going to be a wealth of knowledge. As long as they are not new to the patient, and they've been there for a while, they'll be a wealth of knowledge for you to help treat this patient. So home care occurs within a patient within a home environment. Which represents a spectrum of special health and care populations from infants, older adults, patients with chronic illnesses, patients with developmental disabilities. Also provides servicing as well, like delivering meals, house cleaning, laundry, yard maintenance, physical therapy, and personal care like bathing and wound care as well. So EMS may be called to a residence by the home care provider. So we want to obtain a baseline health status and history from the home care provider. A lot of times if they're like visiting nurses, like DNA comes in, they'll have information about the patient, like a medication list and things like that. So ask them for it. Say, I need a copy of this. If you don't have a photocopier, they don't have a copy to give you, then take a picture of it with your phone, right? Just make sure you delete it after you're done, right? With technology nowadays, you can attach all these documents to your run report via pictures and everything else. It makes life so much easier. Hospice care and terminally ill patients and DNRs and things like that. So again, patients that have these are terminally ill and may receive hospice care at a hospice facility, or they can have something called home hospice as well. For diseases such as cancer, heart and lung failure, end-stage Alzheimer's disease, AIDS, things like that. So most patients have completed a do not resuscitate order and may have a medical order for a scope of treatment. So you want to look at what they have. What are they allowing you to do? Usually if they're on hospice care, they don't receive any more treatment. They don't go to the hospital anymore unless hospice is pulled out. Patients with DNRs, DNR does not mean do not treat, right? Unless they're on hospice care or terminally ill, where they have palliative care or they have comfort care at home only. If a patient is not doing well, we still have to treat them until they are dead. Once they go into cardiac arrest, that's when we stop. Please do not treat a patient because they have a DNR. So comfort care or palliative care by giving pain medications improves the patient's quality of life before the patient dies and allows the patient to be with family and friends. A lot of times you'll see like high doses of morphine given. So follow your local protocols if the patient wishes or legal documents such as a DNR. All necessary documentation must be brought to the hospital with you if the patient is going to be transported. If the patient is at home, the care you give will have a lasting impact on the family, so make sure you show compassion, understanding, and sensitivity. Ascertain the family's wishes about having the patient remain at home or having the patient transported to the hospital. What would you like them to do? Do you want me to transport him? We're more than happy to do that. Or do you want him to stay home? This is your wish based upon his wishes. Do you want him to go? Are they currently on hospice? And if they are, contact the hospice nurse and let them know what's going on. Do they want him transported? They say yes, and we'll take the patient to the hospital. They say no, we'll leave them there. And always make sure you consult with medical control with these patients as well. So contact your medical control. Right. Poverty and homelessness. People who live in poverty aren't able to provide for all of their basic needs: housing, food, childcare, health insurance, medications. Which we kind of talked about this already. They'll wait and wait and wait until they are so sick that they have to call 911, and we have a very critical patient. And we've seen that happening more and more. It also happened during COVID, when COVID was at a big spike for hospitalizations. A lot of them would wait and wait and wait until they got so sick that they ended up getting intubated in the field. Homeless population include patients with mental illnesses or prior brain trauma, domestic violence victims, addicts, and impoverished families. So we want to make sure that we advocate for all patients. I don't care if they're homeless, not homeless, disability, no disability. We treat everybody the same. You need to be an advocate for that patient, right? If you have a high risk refusal patient, so they don't want to go to the hospital, but they have active chest pain, call medical control, talk with a physician, pass the buck. Please do not take that responsibility on your license. Pass it along to a physician, document their name, put it in your narrative, spoke with doctor or whatever. At this hospital, we had a consultation. He stated, do not transport the patients, right? So again, talk with a doctor. All right, so let's cover some review questions. Which of the following is a developmental disorder characterized by impairment of social interaction?
B.
Right. The answer is B. Great. Known risk factors for Down syndrome include
E.
known risk factors for Down syndrome.
C.
C.
All right. C it is. Number 3, which of the following may be difficult to perform on a patient with Down syndrome? Something that you guys are not going to do.
Intubation.
And
D.
D. Yep. Intubation. Number 4 is C. Here's the question, by the way. Most patients with the disease also have hydrocephalus.
D.
Yeah, C it is. I'm a little too fast on that one. What does dope mnemonic help you to recognize?
Dumb neighbors. I'm sorry.
A.
A. Yep, good job. A it is. Dislodgement, obstruction, pneumothorax, equipment failure, dope. I make all my medics memorize this because we take a lot of ventilator calls out of the hospital for newly intubated patients. And they need to understand what dope stands for because that will help them it'll save their butt if something happens. So A it is. What device is placed directly into the stomach to feed patients?
E.
C.
Yes.
So colostomy, ileostomy, take waste out. Central venous catheter, obviously, is a venous catheter placed in the subclavian vein. And gastrostomy tube, or G tube, is feeding tube.
My niece has one of those, and she was a preemie baby, so.
I kicked her.
Yeah. I think I saw that at the very last part. What do vagal nerve stimulators do? Perfect. D. Number 8, an important part of the assessment process for a patient with special needs is to do what?
A.
B.
Okay.
A. Interaction with a caregiver of a child or adult with special needs will be extremely important. But you're right, Sean, though. Also, interaction with a patient is also important as well. So this is so let me go back for 1 second. This is something like you'll find in a National Registry question. You have 2 answers that are very correct and 2 that are like not correct at all. And Sean picked the 2 that are correct. Which one's more correct than the other? Hey, Sean. All right, number 9. What improves a patient's quality of life shortly before death?
B.
B.
C.
Good.
All right, you guys ready for this one? The answer is C. Comfort care. Remember, hospice care provides 24/7 nursing in a home, but comfort care provides that pain medication to help their last few days. They put them on comfort care measures.
My mom actually just passed away, and those were the options that they gave us.
She was on C.
He was on C, the comfort care measures.
Yeah. The hospice care, actually, they called around to all the hospitals, and the closest one was down in Connecticut. That was the closest bed they had available, so.
Oh, that was for dialysis.
Oh, yeah, that's for dialysis, but.
Yep. Number 10, the EMTALA Act states that very interesting, they added this question into here. B, still got a treat, even though they have no ability to pay. All right, let's take 5 minutes and we'll come back with the next chapter.
Sounds good.
This conference will now be recorded.
All right, so transport ops. Let's go through all this stuff here. So risks and responsibilities of emergency response. I'm going to try to stay off my soapbox on a lot of this stuff because I can tend to nice. I can tend to go off on my little tangents about emergency response and how you should respond with lights and sirens, not lights and sirens. I will try to keep that to a minimum because I have my thoughts and my theories behind it. The risk and responsibilities for transport, safe air medical operations, things like that, as well for air medical and criteria for utilizing air medical response. All right, let's go. Let's see, infectious disease, also how to decontaminate equipment as well as decontaminate the ambulance. I think we've hit that a lot. You guys have learned that during your clinical rotations as well. So like I said, a lot of this stuff here we'll go through pretty quickly. Today's ambulances, they're stocked with standard medical supplies. Let's go back a little bit. Horse-drawn ambulances were used in major U.S. cities in the late 1700s. Hospitals started their own ambulance service in the 1860s, and ambulance attendants traveled with limited medical supplies. Today's ambulances are now stocked with the standard medical supplies, and many are equipped with state-of-the-art technology that can transmit data directly to the emergency department, like EKGs. Today's emphasis on rapid response places the EMT in greater danger while driving the calls. Although technology can aid in directing the route and mode of response of the ambulance, it is also distracting and it potentially places the crew at a higher risk for crashes. But now we're putting ourselves at risk by saying, okay, you're going to respond lights and sirens to this because it meets Delta Echo level call to Alpha level response is always going to be flow of traffic. And that's also not a bad thing because now it's also saving people. And bigger cities, and I'll use AMR for example, out in Manchester, when I worked for them, anything that came in as an Alpha or Bravo level call had to be flow of traffic. You could not turn your lights and sirens on. It was against policy of the city. Charlie Delta Echo level calls, those are code 3 responses. And they're doing that a lot in Massachusetts too. Code 1 versus code 3 response. And dispatch will tell you, this is how you're going to respond with your ambulance. So the ambulance is a vehicle that is used for treating patients. We already knew that. The first use of motor-powered ambulances occurred in the late 1800s. And today's ambulance designs are now led or based on NFPA 1917, which is the standard for automotive ambulances, and on suggestions from ambulance industries and from the EMS personnel. An enlarged patient compartment is one of the most significant developments that they've come up with. The first responder vehicles initially respond to a scene with personnel and equipment to treat the sick and injured until an ambulance arrives and starts getting ready for transport. So we have first response, which would be like your fire departments or fly cars, or even in some towns, like even around where I work, they may show up with an ambulance, but they might not transport until the transporting ambulance shows up. So components of this would be obviously the driver's compartment, the patient compartment, which is big enough for 2 EMTs and 2 supine patients. Now, they've gotten away from that. So again, some ambulances have the bench seat to be able to transport 2 patients on backboards or supine. A lot of the newer ambulances now do not have that ability anymore. They've gotten rid of that bench seat and went to like an action working area. They have to have 2-way communication and the design and construction that ensures maximum safety and comfort in the back of the ambulance. They put these things through a lot of different crash tests and everything else. There are 3 different types of ambulances, type 1, type 2, and type 3. Type 1 is your conventional truck cab chassis. So so type 1 would be like your F-Series, your Chevy chassis with a pickup truck style front. Your type 2 is your standard van, forward control, integral cab body ambulance. And your type 3 is your specialty van cab with modular ambulance body that is mounted on a cutaway van chassis. So you have type 1, type 2, and type 3. What they don't tell you is type 4. And in some books, they actually talk about the type 4 ambulance, and the type 4 ambulance is the like first response SUVs, things like that. So ambulance licensing or certification standards are established by states. The Star of Life emblem is affixed to the sides, rear, and roof of the ambulance somewhere. Now, not all ambulances have stars of life in the sides. And for a long time, they did put these on the roof. They were required. That way there, they knew when helicopters came in for air medical, they knew that that was the ambulance on the ground. But then companies started using the roofs of their ambulances not only for the Star of Life, but they would put their non-emergency number on the roof of their ambulance to pick up more transports at hospitals. The people from up above looking out the windows could see their phone number. So now they use it as a billboard as well. As you can look at here, here's the different types. So your type 1, type 2, type 3. Yeah, sorry, type 2, type 3 ambulance. All right, so phases of an ambulance call. As an ambulance call has 9 phases. Preparation, dispatch, en route, on scene, transfer the patient to the ambulance, en route to the receiving facility, transporting, at receiving facility, delivery of the patient, en route back to the station, and then when you're back to the station, doing a post-run inspection. That's restock all your equipment. So there's 9 phases of an ambulance call. All right, make sure the equipment and supplies are there, proper places, and ready for use. Go through your truck, do your truck check. Make sure everything is needed for the calls. Right? It's not a good thing to have stuff missing. Store equipment and supplies according to how urgently and often you need them when they are used. Right? So I'll show you guys this in the next slide in a preparation here, but life-threatening, usually airway is by the airway seat, the captain's chair. Okay, airway supplies. Then you go down the cabinet, you'll see trauma supplies, IV supplies, right? Depending on where things are located. But everything is located to where you're going to be performing that procedure on that patient that's there. Right? Does that make sense? You try to make sure everything's located in specific areas so you don't have to get up. Like airway shouldn't be down by their feet. It needs to be by their head. Test all your equipment. Make sure the batteries are good. Make sure everything is charged. Make sure you have fluids on the fluid warmers. You know, things like that. All right, change. There we go. All right. Cabinets and drawers fronts should be transparent and labeled, so you can see through it and you know where things are located. They should also open easily and close securely as well. If you open something up in a cabinet and you take something out, please close it, because when you're going down the road, stuff falls out on top of the patient. The last thing you need is a heavy object coming out and smacking a patient's face. Check all your equipment. Okay, that's an old school CPR board. Make sure you have gloves and sharps, disposals. Airway, ventilation equipment, basic wound care, splinting supplies, childbirth supplies. I'm a big fan of having 2 OB kits on an ambulance because you know what? Twins can happen. Patient transfer equipment, AEDs or cardiac monitor, medications. Make sure you check the dates on your medication. Make sure nothing's expired. Communication equipment, other regionally appropriate supplies that we accept on the ambulance based upon regions or states. Airway ventilation, oropharyngeal airway for adults, infant, children. Nasal airways, 2 portable artificial ventilation devices, pocket mask, background mask. Go right down through the entire thing. And everybody here has already done ride time. So you guys should have gone through a truck checklist at some point or gotten in the back of an ambulance and looked through the cabinets. You should be able to see all this stuff here. Splinting supplies, childbirth, AEDs. Make sure you have your short boards, long boards, triangular bandages, cervical collars, head immobilization devices if your state still requires it. Different types of splints, board splints, fractures, or what they call frac pack splints. Those are board splints as well. They can be utilized for pediatrics. This device right here is called a SAM splint. So I'll circle here. SAM splint here. These are board splints, which we're going to be playing with on Sunday. These are pediatric board splints. These are frac packs here. Honestly, this is stuff from inside of an OB kit. You have umbilical clamps, bulb suction, things like that, warming blankets, pads as well. Looking at medical equipment, patient care, transfer stuff. Make sure you have your first in bag with all your stuff inside of it. We carry hover pads, hover mats on our ambulances as well for we work. But jump kit, medications. Go through all your meds. Make sure everything is there. One of the big devices we're utilizing now is scoop stretchers, things like that. Again, all this stuff here, you guys should have gone through during your orientation and your ride time. Safety and operational equipment, personal safety equipment. As you can see, traffic vests here, as well as toolboxes and things like that you might need to utilize. Make sure you have gowns, face shields, masks as well. Looking at safe operations as well, looking at pre-planned and navigation equipment, make sure you have GPSs. Some have what they call MDTs or mobile data terminals in the ambulances. Local hospitals, GPS. Make sure you know where things are. Go out and do road familiarization and know where your hospitals are before you start working in your area. At least one EMT. What was that?
For my orientation for riding in the ambulance for Socopy when I started there, I wasn't allowed to leave driver training until I went code 1 or code 3 to each hospital we serviced.
Yep. Yeah, at Action, I developed a pretty extensive driver training program they all have to go through when they get hired. And really, it follows the VFIS curriculum for driver training. So basically, the program that you're going through, Dave, I use a lot of that. And I also utilize what Maine has gone to. Maine has a very strict driver training protocol for fire apparatus, not ambulance, by the way. Fire apparatus is completely different. And I brought that to Action Ambulance and utilized the Maine program for fire apparatus, but I tailored it for EMS.
Are you telling me that Maine's strict on something?
When I went through my firefighter too, I also did driver training through with the fire department.
Yep. Good thing to have, especially getting that driver operator certification. Maine requires it. If you're an EMT and you're a driver of the ambulance, within 6 months of date of hire, you have to have a EVDT program through the VFIS or the Maine AVOC. Those are the only two accepted. So Maine Fire Service Institute or Maine EMS approved program. So you have to have at least one EMT in the patient compartment during transport. EMRs do not count. EMT or higher in the back at all times. 2 EMTs are strongly recommended. Again, that's staffing. We're not going to put 3 people in an ambulance and staff it that way. Some services have a non-EMT driver and a single EMT in the patient compartment. That still does exist, and Maine is one of those states where you're not required to have 2 licensed personnel in an ambulance. But it's been discussed at the state level that they might change that. Preparation phase. Again, daily inspections, ambulance inspection, cleanliness, quantity and function of medical equipment. Make sure your stuff is clean. The last thing you want to do is put a patient in the back, have them see blood all over the equipment. Please clean your truck. Disinfect it, clean it, spray it down for COVID nowadays. Make sure you have fuel in your truck. Last thing you want to do is come into an ambulance with half a tank or quarter tank. Some transports take a while, so transmission fluids, oil, engine cooling, batteries, brake fluid, engine belts, inflation pressure on wheels, tires. Make sure everything's good to go. Make sure your horn and siren work. This is all normal routine checks. Then going through all your equipment. Make sure everything is working and cleaning. Wash your ambulance. You are a rolling billboard. Please make sure that you get the money from your town for the next year. So take care of your equipment as well. Review safety precautions, traffic safety rules and regulations. Properly secure oxygen tanks in your ambulance. Make sure that you check your oxygen levels. Non-rebreathers use a lot of oxygen. You can drain your tanks pretty quickly, so make sure that they are full, or within whatever your protocols are within your agency, based on standard operating procedures. Dispatch phase. Dispatch must be easy to access and in service 24 hours a day, 7 days a week. Dispatch cannot go down. If it does, it has to be rerouted to another dispatch center. They may be operating by local EMS or by a shared service. So you may have what they call PSAPs, which is a public safety answering point. So as we know, like New Hampshire uses Concord, and then they go out to the local fire departments or dispatch centers, and that's how they get dispatched out. And everything is EMD, which is emergency medical dispatch on top of that, where they basically tell people how to treat somebody at home. The dispatcher should gather and record the nature of the call, name and present location, and a callback number, location of the patient, number of patients and their severity and condition, and other pertinent information as well. The en route to the scene is the most dangerous phase of the EMT because crashes may cause serious injuries. Look at what just happened this morning. Right? Wilmington, Mass. They were responding to a motor vehicle accident on 93 northbound. They were going southbound, and they stopped to turn through the cut-throughs on the highway. And someone, for some reason, wasn't paying attention and hit the ambulance. Right? Now, that's also an area that Action Ambulance, where I work in Mass, we cover Wilmington as well for advanced life support. They only provide basic life support on their trucks, and we're the ALS intercepts. We sent 3 of our ambulances to transport firefighters to the hospital. Right? Very dangerous. Pay attention. Make sure you're wearing your seatbelts, shoulder harnesses in the back of the truck. Make sure you're wearing your appropriate gear. Review the dispatch information. Right? If it's a lift assist, we do not need to be running lights and sirens to lift assist. Okay? It does not need to happen. Right? Stub toe, broken fingers. These are ones we can go flow of traffic. Technically, they should get in their own car and drive themselves, but that's just another day. Right? Don't put yourself in a situation that you're going to get into an accident. And then transporting patients as well. We'll get into that later, but I'll talk about lights and sirens in transport and how you can lose your entire career because you decided you wanted a lights and siren to something that wasn't critical. Perform a scene size up when you arrive at scene and report your findings to dispatch. Look for safety hazards. Evaluate the need for additional units. Determine the mechanism of injury or nature of illness. Evaluate the need for spinal mobilization and follow your standard precautions. If it's an MCI, you need to establish an MCI through dispatch. Once you say we have a MCI, then there's no chance that you're going to have any negligence or an abandonment of a patient. Right? You can leave a patient who is bleeding out and go to the next one. Right? That is part of triage. You have to establish an MCI so that way there all your abandonment protocols go out the window. When you arrive on scene, you want to make sure you have safe parking. There's a whole entire class on this, on how to park at emergency scenes. Everybody should be parked on the same side of the road, right? Ambulances belong in work zones. They're not blockers, okay? The ambulance should not be first in line. A big fire truck, red shiny, or yellow or white, or whatever color your fire trucks are, those should be your blocking units. On the highways, they use ladder trucks for that because it takes up 2 lanes. They're that big. You've got to protect yourselves. And the fire needs to protect the scene for you if you're coming in with the ambulance. Park 100 feet before or past the crash, but make sure that you're in the work zone, right? Do not park on the opposite side, and always try to park upwind and uphill of a hazardous material. The last thing you want to do is have it leak down into your vehicle or the wind blows down hazardous materials and you get sick. Please do not turn your emergency lights off if you're on a roadway. If you're on the roadway, on a scene, leave them on. Protect yourself. All right? Keep a safe distance, as you can see here. If traffic is moving down the lane, traffic direction, as you can see, the big red shiny fire truck is a blocking unit. If a vehicle hits that, the chances of that rolling over, unless it's another semi truck hitting it, they're going to ricochet off of that and they're going to protect the scene and protect everybody that's working. You need to have blockers. Traffic going this direction here. This is your blocker unit. Okay, from this area here over the way over here, this is the work zone. Work. I'm not going to spell it out with my fingers here, but not a huge fan of flares, traffic cones, and if you look at main standards as well, so Dave, this is for you, they have to be a certain distance apart as well.
Correct.
Everything's good. Yeah.
I was just gonna say that, yeah, flares are really dangerous, especially with car accidents, with leaking fluids, and you got hazardous material actually rolling down through. I used to haul propane, and I'd see flares out from the cops, and it'd make me nervous.
Right. I circled the word cones. I'm crossing out the word flares. Right. And other things too are the emergency scene ahead signs. If you have the ability to get those and place them before the scenes, it helps slow people down. Hopefully.
I've noticed like the fire trucks, when they send out their utility trucks, they have those signs they put up, and at least in the area in Maine we work.
Yep. Stay away from fires, explosive hazards, downed wires, and unstable structures. The ambulance does not belong there, right? If you see a vehicle into a pole, you want to be 2 pole lengths away with the ambulance, okay? Try to, that's kind of a rule of thumb, 2 pole lengths away. There we go. As far as traffic control goes, For Maine providers, you cannot do traffic control unless you've taken the Maine State Traffic Control Safety course. Interesting, right? You cannot do traffic control in Maine unless you've taken a course for it.
Which is not a bad course. I've taken it.
It's not. I'm one of the instructors for it. So I teach it all the time. Well, I used to, anyways. Traffic control is intended to ensure orderly traffic and warn other drivers and prevent other crashes. Place warning devices on both sides of the crash. Make sure people know that there's a crash ahead if you can. Warning devices are phenomenal, especially early warning. The patient must be packaged for transport. This is your transfer phase. Please put on all the seat belts, including the shoulder harness. If you get into an accident and the shoulder harness is not in place and the patient dies, you are held responsible for that. All right? I want to say it's called negligent homicide because you've now killed your patient because you were negligent at your job. Right? You will lose your license. You will end up in jail. You will lose everything you've ever worked for. I'm not trying to scare everybody away. We provide you with the equipment. Use it. Please use it. Right? When you're lifting the patients, make sure you're lifting the patients with 2 people. Right? Now, they've gotten away with like power cots, power load systems, and all that kind of stuff. But you know what? Technology does fail. So make sure you know how to use your stretcher in case the technology does fail on you. When you are ready to leave with the patient, inform dispatch you are transporting, how many patients you're transporting, and where you're going to what hospital. And then they say beginning mileage. Not a lot of services do that. Some do, some don't. If you are a male transporting an underage female for a psych in the back of an ambulance, give your mileage. Right? It helps protect you. Monitor the patient during condition during a route. Remember, stable every 15, unstable every 5. Contact the receiving hospital and do not abandon the patient emotionally. Be aware of the patient's level of need. Right? Don't just sit behind them for the entire ride. Tell them to keep quiet and just monitor their vitals. Interact with the patient. Okay? Sean, you still there? Maybe. I think he's still there. I'm not sure. I can't see the roster because I'm teaching the class. But I had Sean talk to a patient the other day for most of the ride. Right? Yep, perfect. Okay. Yeah, so I had him talking to a patient most of the ride for a trauma patient we took down to Portsmouth Hospital. Because I gave him a bunch of meds, I was monitoring stuff and everything else, and he had a great conversation with him. And that's what I'm doing, is not just trying to keep him awake, but we were assessing his mental status the entire ride. Right? So great job with that. Delivery phase, let the dispatch know you're at the hospital. Prior to delivery, though, right, you want to make sure that you also radio the hospital and let them know with advance what you're coming in with. Trauma patients, trauma alerts, give them a half an hour ETA. Let them know a trauma is coming in so they can prep for it. Don't just give them, oh, we'll see you in a minute. Right? That's horrible. That's very bad for patient care because they have to wait.
Yeah, we had a stroke victim, and we let him know ahead of time to get the stroke team in place.
Yep. So you notify a stroke alert, the stroke team gets ready, and they take you right to CT. You have to actually call, though, from the scene and give them the patient's name and date of birth so they can start pre-registration so they can actually run the machines.
Is it normal practice or written down somewhere that we do the radio call 10 minutes out? Because I noticed we do that here at Socopee and Leamington Rescue.
It's not written practice. Some hospitals require 20 minutes, some require 10. You know, some only get 3 minutes, depending on where you are. If you're like right across the street, like in Wolfboro, when I was over at Wolfboro Bay, I can't give them a 15-minute ETA because literally it's a 0.2 mile transport. You know, So you should really call in with enough advance warning so they know what to expect. 10 minutes is not bad. Trauma patients, strokes, they should have more notice. So when you give a patient care report to the nursing staff and you give a verbal report, you want to give the history of the current illness or injury, pertinent positives and pertinent negatives, nature of illness or mechanism of injury, relevant past medical history or surgical history, medications, allergies, pre-hospital treatment, and its effects. So if you gave oxygen, the guy would, let's say the patient had a pulse oximetry of 70% after a non-rebreather replacement, he went to 94, right? Let them know the trends that you see. Complete a detailed patient care report, PCR, and then restock your items at the hospital if possible. When you are en route to the station, inform dispatch that you are clear and if you're in service or out of service. Make sure you disinfect and clean your ambulance before you leave the hospital. Mop it out, spray it out, whatever it may be. Most ambulances now have COVID sprayers. After a call, spray it down. Doesn't hurt, right? You don't know if people have COVID or not anymore. You have no idea. So just treat it appropriately. Make sure you restock your supplies as well. Your post-run phase, you want to complete and fill out additional written reports that are needed as well. Do a routine inspection. Please make sure your vehicle has fuel in it. Post-run key terms be cleaning, disinfecting, high-level disinfection, or sterilization. It all depends on what the patient has. High-level disinfection would be and sterilization would be the COVID sprays and things like that as well. All right. So after each call, strip linens from the stretcher and place them in a plastic bag or a designated receptacle. Discard any medical waste and wash contaminated areas with soap and water. Even sprays are perfectly fine as well. Disinfect all non-disposable equipment used for patient care. And clean the stretcher with a germicidal or virucidal solution or 1 to 100 bleach dilution. And we want to make sure we clean the spill. Create a schedule for all routine full cleaning of the emergency vehicles as well, and create a written or policy procedure for cleaning of each piece of equipment. So a lot of us refer to manufacturer recommendations for that kind of stuff for policies. All right, let's go over some defensive driving techniques. So according to the National Highway and Traffic Safety Administration, between 1992 and 2011, there were approximately 4,500 motor vehicle crashes involving an ambulance each year. Each year. It's a lot. 4,500 motor vehicle crashes a year with an ambulance. Some were fatal, some were just minor fender benders. Please take a defensive driving course, EVOC, EBDT, AVOC, whatever it may be. Take a class. Some states require emergency vehicle operations courses. We've already covered all this. Other characteristics are the physical fitness and alertness, emotional maturity, stability, and due regard for the safety of others and preservation of property. Right? If you've been drinking alcohol, don't come to work. If you've been working long shifts or multiple consecutive shifts, it's dangerous. Now, if you're working, or I am, 48-hour shift, not bad. Right? We're not super busy. But if you're running 15 to 20 calls a shift, right, you probably shouldn't be working another 24-hour shift. And this mandatory force over stuff, and we're seeing a lot in fire departments, is becoming dangerous. Because now we're expecting people to be forced over, and it's like, you got to stop. I was talking to an EMT firefighter, a career firefighter, because of COVID and all the force over. She lasted 2 years and she got done. She goes, I'm done. It burnt me out. I'm going back to doing something else. We're burning out our people because of COVID. Safe driving practices. Speed does not save a life. Good care does. Okay? There's no need to do 100 miles an hour to an incident. There isn't. You're not going to do anything good if you crash. Wear seatbelts, shoulder restraints. Become familiar with how their vehicle accelerates, corners, sways, and stops. Stay in extreme left-handed lane on multi-lane highways. Right? People pull to the right. You start passing people on the right, common sense. They see an ambulance or lights and sirens, some kind of emergency vehicle, they pull to the right. So if you pass on the right and they pull to the right based on instinct, they're going to run into you. Right? So be careful. The siren risk-benefit analysis. If the patient, the way I would explain this is life, limb, eyesight. Those are necessities of life. Life, limb, eyesight. If you're gonna lose a limb, you're gonna go, something wrong with your eyes, life-threatening conditions, those require lights and sirens. Other than that, they really shouldn't be lights and siren transports. Driver anticipation. Always assume that motorists around your vehicle have not heard your siren or public address system or see you. Always drive defensively. Right? Be careful.
Another thing I learned when you go back to lights and sirens there,
Yeah.
not everybody hears the same tone that we use all the time. Like if you're in the tone 1 or whatever you want to call it, some people don't hear that tone. So when I went through driver training, they told sometimes it might be beneficial to mix up your tone, go to another tone, and then come back to the original so that that tone changes for the car you're coming up on, if that makes sense.
Absolutely.
I've seen a lot of people do not react to the primary tone we use, but as soon as we switch tones, then you could see like they got the aha, oh crap, there's an ambulance behind me.
Right.
And then they start prepping to get to the right side.
So so what you're talking about, Dave, also is whale, yelp, and phaser, or what they call a T3 siren. Those are the old school 3 basic sirens. Now, there's other ones called high-low, like the European vehicles. There's power calls. People are like, oh, that's the best siren. It's in sliced bread now. You know, we use power calls so people can hear that better. Then you have the federal Q units on fire trucks that are loud and obnoxious. But again, there's so many different siren types that are out there. When you're approaching an intersection, you need to change your tone. Right? There's something called siren side, where you get droned out. You kind of like drone out driving with a siren going with the same tone over and over again. And then that's how people get into accidents, and they get that tunnel vision of the siren side. So pay attention. Try to avoid being tailgated from behind. If someone's tailgating you, pull over. Let them go by. All right, don't slam on your brakes, and then call them in. Get the license plate number and call them in. Never get out of an ambulance to confront the driver. Okay, please do not pull over, open the back door, and throw bottles of urine at them. Probably not a good idea. Be aware of blind spot.
Bottles of urine at action.
I don't know what you're talking about. No.
I'm checking.
So again, don't do something stupid that's going to get you shot, killed, or injured. Just keep going. Treat your patient. If you're fighting with a driver, then you're not taking care of your patient. You're now negligent. You're abandoning your patient by taking care of somebody else. Just pull over. Excessive speed is unnecessary. Please do not speed with these trucks. Okay. A lot of times we're in the back of the ambulance and we're not buckled because we have to move around to do certain things, right? So slow down. Siren syndrome or siren side causes drivers to drive faster in the presence of sirens due to increased anxiety. Take a breath. Slow down. Right? Vehicle size and distant judgment. Understand the vehicles that you drive. If you work where I work in Action, we have all different size vehicles, and you guys have all seen them. From a big monstrosity of an International to the small Sprinter vans and everything in between. Right? Know your trucks. Train on your trucks. Go through the cone courses. Understand we have trucks with air brakes, non-air brakes. You know, so learn your trucks. Learn the stuff that you work with. Right, road positioning and cornering. Keep the ambulance in the proper lane when turning. Enter high in the lane and exit low. All right. Please take turns slow when you're transporting. There is a patient out back, and flat out, this is more street stuff. If you make my patient vomit in the back of the ambulance because if you're driving, you're going to clean it. I am not. So again, please make sure that you drive appropriately. We do not want to have this patient aspirate vomit into the lungs, into the airway, and cause more of an infection and more issues. Weather and road condition. Ambulances have longer braking time and stopping distances. They are heavier, right? So again, hydroplaning, water on the road, decreased visibility, ice, slippery surfaces, just slow down, know your conditions. If you're on an emergency call and you are using warning lights and sirens, you may be allowed to do the following. Park or stand in a legal location. Proceed through a red light or a stop sign. Drive faster than the speed limit. Drive against the flow of traffic. Take left or center to make illegal passes. You need to drive with due regard. Okay. A lot of departments make a policy, no more than 10 miles an hour over the posted speed limit with lights and sirens on. If you do not drive with due regard, you will lose your driver's license if you get into an accident. And believe it or not, police officers will pull you over in an ambulance. I've seen that happen multiple times with private sector ambulances for not wearing seatbelts, for going too fast in residential zones, right? You're not invincible working on an ambulance. The last thing you want is someone to file a complaint against you. That can cause you to lose your job, right? So drive with respect. Remember, you are a rolling billboard with your name plastered all over it. All right. Emergency vehicle is never allowed to pass a school bus that is stopped to load or unload children. You cannot pass a school bus. You have to wait until they tell you to come forward. All right. Right-of-way privileges. Emergency vehicles have the right to disregard the rules of the road when responding to an emergency. All right. All I'm going to say is drive with due regard. Do not put anybody in danger. Go ahead. No, you're fine.
So going back to the school buses, we talked about how they do literally have to flag you by because they want to make sure all the kids are out of the road. But she also added that another vehicle we cannot pass is the USPS Postal Service cars while they're in their working mode.
Correct.
Without obviously having us flag us by. So.
Correct. Now, I don't think I've ever seen anybody pursue that, but that is correct. The United States Postal Service has more right and authority on the road than we do. Use of escorts as a guide when you are in unfamiliar territory. You don't see escorts very often anymore when it comes to escorting ambulances to hospitals. It's actually quite dangerous doing so. We used to do it a lot, especially we did transfers out of Maine Medical Center going down to Boston Children's with the Boston Children's truck. Yeah, very true. They have a lot of lights.
I've been escorted twice now.
Yeah. Intersection hazards. Just because you have red lights and sirens running does not mean you can blow through intersections. If it is a red light, you still have to stop. And if it's a multiple lane intersection, you're supposed to proceed lane by lane very slowly to stop, look, stop, look, stop, look, and then proceed. If you blow through a red light with lights and sirens on and you cause an accident, you are at fault, right? You are at fault if you are driving. You do not want to hurt somebody because that's vehicular manslaughter. You do not want vehicular homicide. You do not want this stuff to happen to you. This ends your career. So please do not blow through intersections. Unpaved roads. please do not take ambulances down class 6 roads. You tend to break stuff. Okay? If you're going down an unpaved road that's like a dirt road, go slow. School zones. It is unlawful to exceed the speed limit, even with lights and sirens on. You cannot fly through school zones if the lights are operational. School zone lights. Honestly, at highways, shut down your emergency lights and sirens until you reach the far left lane. Crossing lanes can cause an accident. That's kind of the laws and regulation stuff. Again, follow your local laws by state. Distractions, obviously driving, focus on driving, anticipating roadway hazards. So plan for stuff to happen. Minimize distractions of like mobile terminal dispatching stuff, GPSs, mounted radios, cell phones, eating and drinking while driving, having your radio on, music radio, and things like that. Just be prepared.
Call that stereo tab.
Now, listening to music on a long distance transfer, if you're doing that kind of stuff, now you're not driving lights and sirens. So it's different. Right? When lights and sirens are on, please do not play any kind of aggressive music that just makes you want to drive faster. Remember, it is your responsible driving alone to it's your responsibility to focus on figuring out the safest route while mentally preparing for the call, such as situations may demand your complete attention and focus. If you're working on an EMS system in that area, you should know the area that you work in to the most part. I'm not saying memorize every small road in town, but again, know your major roads, know how to get to hospitals, know how to navigate. That's the biggest thing you need to work on. If you're tired, you should be placed out of service for the remainder of the shift until fatigue has passed. Now, if you're tired, let your supervisor know. We can try to work around certain things and move stuff around. Same thing with the captains and everything else. Right? Let them know that you've done like 8 calls, that you need a break. A lot of times they can rotate stuff out to give you the break that you need. Okay, so just again, you got to communicate. All right, air medical transport. I know I showed you guys the video on this one here before in regards to Dartmouth and what they do. Yes, Sean, no one ever does that. All right. Air ambulances are used to evacuate medical and trauma patients, fixed wings and rotary units, helicopters, as you can see here. Right? So these are your fixed wings, rotary down here. Fixed wings are more utilized for longer transports, but they can be utilized. These usually go for patients that are inter-hospital only for distances over 100 to 150 miles. Helicopters are more efficient, but they're also used for shorter distances. For these, you have to have specially trained crews. Usually in these, they have a critical care medic, critical care nurse, and a pilot. And they have different capabilities and different protocols than most of us have. They carry different things as well. So why call for a medevac? If a patient's critical and time sensitive with a long transport to a trauma center, that's when we call for medevac. Same thing with medical calls. If we have a patient having a STEMI, a stroke, that need to get to a stroke center that's 2 hours away, we can call for medevac. All right. So if the patient's critical, like motor vehicle accident, with entrapment, femur fractures, and it's going to take them 20 minutes to get a patient out, call for medevac. Right? If the patient is ejected from a vehicle, and let's say the helicopter says they're an hour away and you're 45 minutes from the trauma center, then transport by ground. Right? I'm not a big fan of setting up landing zones. Go to the hospital that has a pre-done landing zone, helipad, and meet them there. Because helicopters can abort missions if they run into trouble. The last thing you want to do is go to a landing zone you made up in a ball field, and you sit there for 30 minutes, and they go, oh, sorry, we have to abort. That's 30 minutes closer you could have been to a local hospital to start treating with a physician. That makes sense? Yes, no, maybe?
Yeah.
Yes.
Awesome. Okay.
Yes.
Make sure you guys are still awake. All right. We already talked about this stuff here. Scuba diving incidents, near drowning, skiing, wilderness accidents, traumas, candidates for limb replantation, burn centers, hyperbaric chamber, venomous bites, things that would require that. Who do you call? You let dispatch know. Hey, start me DART, Life Flight, Boston Med Flight, whatever. As far as landing zones go, they have to be on a grassy surface between 60 and 60 and 100 by 100 recommended. You got to clear all loose debris. Make sure there's no overhead hazards, and mark the landing zone using cones. They say using cones of vehicles. Do not use cones for this kind of stuff. I don't know why they even say that, because cones can be blown around. Mark the landing site. A lot of people have like landing zone kits instead that actually strobe. The problem with that is that Dartmouth, they're using night vision stuff, so strobe lights can actually blind them. Not so much as flares. Do not use flares if you'll set the grass on fire. It just makes a mess. Headlights need to be turned off as well. So Life Flight and DART, they'll actually come out to your facilities. I used to do this in my EMT classes years ago. I used to have Life Flight of Maine come over and land, and we would do a Life Flight landing zone class. They come over with the helicopter so the crews could see it. But with COVID and everything else, it's been a little more difficult to get this kind of stuff to happen. All right, establishing a landing zone again, move non-essential persons and vehicles out of the way. Always approach a helicopter from the front, not from the back, because remember the rotor blades in the back can spin really fast and chop off your head. Don't want that to happen. Can't really put that back on. Again, we also don't do hot loads anyways. Before they even get out, they shut down stuff prior to. As you can see here, these front blades here can go as low as 4 feet from the ground. So again, approach crouched. I'm not going to approach. I'm 6'4". I don't want to become 4'6". Right. So let's not let that happen. Become familiar with hand signals as well. We do not do a lot of this stuff. We're in the back of the ambulance. Again, I'm not going to teach you guys a landing zone class. Ask your local chief on your department if they can sponsor one. They don't charge for it. They come in for free. Right. We're not going to do this. Those helicopter pilots are very good at landing. Night landings, do not shine spotlights, flashlights, or any kind of light into the air to help the pilot because it can actually blind them. Use low intensity headlights or lanterns that sit toward the ground. That's it, so they can illuminate the overhead hazards or obstructions if possible as well. Let them know where the power lines are and things like that. This happened to Life Flight not too long ago in Maine where they actually went into some power lines. So the crew got out. They didn't get hurt. They didn't crash. They hit power lines and had to land. They couldn't fly again. So they jumped in with an ambulance. Another thing as well is landing on even ground. What they look for is a 5-degree pitch or less. Any more than 5 degrees, they can't land on. Some special considerations, obviously with hazardous material incidents, notify the flight crew that's a hazmat, and landing zones should be uphill, upwind. A lot of times they don't like transporting contaminated patients, so usually they want you to decontaminate prior to as well. Assess for the severity of weather and environment and terrain. Most helicopters limited to flying at 10,000 feet above sea level, and medevac helicopters fly between 130 and 150 miles per hour. But if there's bad strong winds, if there's rain coming in, snow, they're not going to fly in those. They might fly in a little bit of rain, but they're not going to fly in snow. Things like that. They kind of stay grounded. So because of the cabin's confined space, assess the number and size of patients who can safely be transported. Life Flight of Maine is no more than 6 feet tall, or they have to bend the legs. They have to know the patient's weight because they might have to burn off fuel to be able to take that patient as well. All right, let's go over some review questions, and we'll go to the last chapter, and we'll be done. All the following are examples of standard patient care transfer equipment, except standard equipment that we normally keep in an ambulance, except what?
A. Spokes baskets.
Correct. So we carry stair chairs, ambulance stretchers, longboards. We don't normally carry a Stokes basket in an ambulance. So A. The primary purpose of a jump kit is to do what?
B.
Yep, have all the equipment that you will need in the first 5 minutes. D. You have been dispatched to a call for an unresponsive patient. What is the most important information that you should obtain from the dispatcher initially?
I'm gonna go with C.
Kind of an interesting question. They're going with D, the exact physical location of the patient. I mean, if they're not breathing, we don't know where they are. That makes it kind of difficult. So you got to look at what would be the most best answer for that. It would be where are they actually located. While en route to a call for a major motor vehicle collision, the most important safety precautions that you and your partner can take is, or are, right. D, wearing seatbelts. Which of the following is not a guideline for safe ambulance driving? Which is not? So I see some of you guys picked A, and the correct answer is C, using one-way streets whenever possible. In Maine, the law states that if your siren is on, your lights are on, your siren has to be on at all times. There is no code 2 response. There's that. So answer is C. Number 6, at what speed will the ambulance begin to hydroplane when there is water present on the roadway?
You can do 25 in hydroplane.
Very close. The correct answer is B, so 30 miles an hour. The most common and often most serious ambulance crashes occur at intersections. It is. Number 8, the recommended dimensions for a helicopter landing zone. Recommended.
C.
C. C it is. Which of the following statements about helicopters is true?
A.
All right, A it is. The blades can dip as low as 4 feet from the ground. Number 10, upon arrival at a scene where hazardous materials are involved, you should park the ambulance.
A.
A.
All right, A it is. All right, that's an hour of lecture. Let's take 5 minutes. Go back and do the last one for vehicle extrication, and then we're done.
This conference will now be recorded.
All right, so let's talk about vehicle extrication, special rescue, chapter 38. All right, so we're going to talk about vehicle extrication, safe vehicle extrication, and the use of simple hand tools. Like I said, we're not going to get too in depth with this kind of stuff, but just kind of enough to kind of give you some introduction to it. So you will usually not be responsible for rescue or extrication. Okay. Rescue involves many different processes and environments that are there. It could be from high, low angle, structural, trench, swift water, ice, water, vehicle extrication, all these structural collapse, everything that could be out there possibly. And every one of these requires training beyond the EMT level. So this chapter will teach you the basic extrication concepts, but NFPA has two different standards. One is 1670, the other one's 1006. And NFPA 1670 goes really involved in awareness, ops, and technician level. And you just have to be certified to a specific level on what your department will handle to be able to provide these types of rescues. Right, there's all different ones that are out there. So with that being said, extrication requires mental and physical preparation, right? Not just mental and physical preparation, but you also have to remember the priority is to provide patient care. So what I teach in a lot of my other classes are, especially in vehicle extrication, is we're taking the wreck away from the patient, not the patient away from the wreck, right? So it requires a lot of training, education, and just hands-on on the equipment that we have to be able to provide these types of removals. Consider the safety of yourself and your team first. Safety begins with the proper mindset and personal protective gear. If you're not assigned gear, then don't do the job. If you're not trained for that type of job, then don't think that you are and try to put yourself in harm's way. Equipment and gear should be anticipated based on the hazard. Protective gear may include turnout gear, helmets, hearing protection, fire extinguishers, blood and fluid impermeable gloves, leather gloves, or disposable gloves, over the disposable gloves as well. So vehicle safety systems can become a hazard after a collision. We have shock absorbing bumpers that may become loaded and they can release and injure you. So if you're too close to the bumper and they can release, it comes out about 4 to 6 inches or so, and they can take out your kneecaps. If they're on fire and it pressurizes, it can actually shoot things out like missiles directly through, and it will actually penetrate through turnout gear. It can actually do puncture wounds on yourself. Approach the vehicle from the sides of the vehicles, okay? Manufacturers are required to install airbags in all new cars. Some of them have 30-something different airbags in them, all over the place, from seats. It all depends on what company they are. The most common places for airbags: passenger, driver, knee, seat, curtain airbags are some of the most common ones you're going to find. And these come out at approximately 300 miles an hour. So picture one of those hitting your face. All right. Airbags fill with a non-harmful gas on impact and can quickly deflate, but the detonator device inside is hot enough to fry an egg on. So again, and it's also filled with like a lot of cornstarch. So it may look like it's on fire when it really isn't. Airbags located in the steering wheel and in the dash on the front passenger side. Steering wheel comes out approximately 12 inches. And the passenger side comes out approximately 36 inches out, depending on the size of the vehicle. You do not want to put yourself in harm's way. And just because the airbag's deployed does not mean that they can't deploy again. They do make something called two-stage airbags that can have them deploy twice. One comes out at a slower speed than the other based upon the type of impact that you have. The haze in the vehicles in which the airbags are deployed usually caused by cornstarch or talc, used to prevent minor skin irritations or reducing the friction between the occupant's skin and the airbag itself. So protective gear, including eye protection, is definitely needed to reduce the risk of eye or lung irritation from the substance. So protective gear. Your primary concern is safety, and your primary roles are to provide emergency medical care, prevent further injury to the patient, and you may also provide care as extrication goes on around you. Because you're the EMT on scene, they may just toss you into the vehicle, put a tarp over both of you and the patient, and you have to treat your patient in the dark, holding C-spine, talking to them, or you're running with a flashlight. So having an idea of how extrication actually works is not a bad thing, because then if you hear certain sounds, you'll understand what they're actually doing outside. Extrication is the removal from entrapment or a dangerous situation or position. It doesn't have to be a vehicle. You can be extricated from a river. You can be extricated from the second floor. You can be extricated from the basement when something collapsed on you. Entrapment is a condition where the person is caught within a closed area with no way out or has a limb or other body part trapped. That's entrapment. Extrication, removal, entrapment means they're stuck. So there's 10 phases to an extrication: preparation en route, arrival, hazard control, support operations, gain access, emergency care, removal of the patient, transfer of the patient, and then termination of the incident. So EMS personnel are responsible for assessing and providing medical care. That is our job. Triaging and packaging patients, providing additional assessment and care as needed once patients are removed, and providing transport to the emergency department. It is not our job to pick up tools and start cutting. Now, if you're on a combination department, again, if you're on the ambulance, you're doing patient care that day, right? If you're on the engine, that's a different story, or on the rescue. The rescue team is responsible for securing, stabilizing the vehicle. We do not go into a vehicle until the vehicle is stable, right? And also provide us a safe entrance to access the patient, and then we need to help get the patient out. We have to work in conjunction with fire as a team to remove this patient, because you know the condition of the patient. You're assessing them, you're getting vitals, you know what has to happen, whether it be fast or slow. So law enforcement personnel are responsible for controlling traffic, maintaining the order of the scene, and establishing and maintaining a perimeter. Okay. Law enforcement command, EMS command, fire command. If you follow ICS 700, it's something called unified command. We all work together. No one is more in charge of anything else than anybody else. You have to work as a team. Firefighters are responsible for extinguishing a fire, preventing additional ignition, ensuring scene safety, and removing any kind of spilled fuel. So, preparation. Now keep in mind, for those of you that are currently in fire schools, things like that, obviously this goes a little bit different than what they teach you in fire school, but preparing for an incident requiring extrication involves pre-incident training with rescue personnel for various types of rescue situations. You don't just one day wake up and say, you know something, I'm going to be a technician today, and I'm an expert. You're not. You have to train, learn, study this stuff, and become an expert in that field. Rescue personnel must routinely check extrication tools in their response vehicles, and this reduces the possibility of equipment failure at an emergency scene. You have to train with it. You got to know how to use it. So at 3 o'clock in the morning, you know what you're doing without hesitation. So different than working on the ambulance. Same thing, right? We got to make sure that everything is done. We train with our equipment. We know how to use it at 3 o'clock in the morning. We just wake up out of bed for a critical patient. It should become second nature to you. If it's not, then you have to keep training on that device. The route to the scene, procedures and safety precautions similar to those in the phases of an ambulance call are used in responding to a rescue incident. Do not put yourself in a situation. Use only essential warning lights. Do not park where you will be blocked in. You have to make sure you can transport. Back of the ambulance should point toward the scene to facilitate patient transport, so you don't have to go out into a roadway. In a hazardous materials incident, park upwind and uphill from that hazard. Too many lights on, you still want warning lights on, but too many can cause a distraction or confuse motorists, right? That's why they have what they call primary and secondary lighting. And something else to make a mention, if you're working in a city system, please make sure you turn off your Opticon. That's the device that changes your light, changes the red lights to green. The last thing you want is have your ambulance aiming towards the light system, and it's always staying green one way, and the traffic backs up for miles. Right? So Just keep that in mind as well. Make sure the scene is properly marked and protected. Request additional law enforcement to ensure the road is closed. If the patient is critical and you are running an extrication, close the road down. Protect yourselves. Scene size up is the ongoing process of information gathering and scene evaluation. So again, we're always doing a scene size up all the time. Pay attention for downed electrical lines, leaking fluids, fire, broken glass. Right? If you see a fluid on the ground, please do not rub your finger in it and lick it to see what it is. Those old days of hazmat are gone now. Have situational awareness, as it's the ability to recognize a possible issue and act proactively to avoid a negative impact. You want to make sure you do a 360 walk around, look for a mechanism of injury, down electrical lines, and leaking fuels and fluids. You're also looking for smoke or fire, broken glass, trapped or ejected patients, and the number of patients in the vehicles involved. If you're looking for ejected patients, look around the vehicle, underneath the vehicle, and up in the trees, because patients can be thrown and be impaled on a tree branch somewhere 50 feet above you. Look up, down, all around, every single time. While looking for the vehicle, note the damage. If you see a bent steering wheel, it may indicate a face or thoracic trauma. Imprints on the dashboard may indicate lower extremity injury. Right? If you see starring in the windshield, it could be indicative of a head injury. Pay attention to the mechanisms that are there. Unrestrained past restraints or unrestrained patients may also have contact injuries as well as secondary injuries from the rollover or whatever it may be. Check the windshield for spidering. Include your findings in your documentation. Take pictures of the car. We have technology now. Everybody has a cell phone with cameras on them for the most part. Take pictures and then upload those pictures to your own report. It's documentation. Evaluate the need for additional resources such as extrication equipment, fire department, law enforcement, hazmat, utility company, air medical transport, advanced life support units. You need to make decisions. If fire is not there, then relay that to the fire department coming in if you're a private. If you're a municipal ambulance, you have the ability to make those calls and make those calls. Look for spilled fuels or other flammable liquids or anything else that could be there. Electrical short or damaged batteries. Rain, sleet, snow, crashes that occur on hills, violence. Right? Pay attention to everything. Sometimes post-crash fires are started when sparks ignite the fuel that's been spilled. Right? Be alert for weapons for patients that are violent. Road rage. Don't put yourself in a situation where you're going to be hurt. Coordinate your efforts with the rescue teams and law enforcement, and you want to make sure you communicate. Let them know how bad the patient is. Start talking to the incident commander as soon as you arrive. Say, what do you have? What do you need from us? What is the patient condition? How many patients do you have? So we can start prepping. You become a member of the rescue team, but do not do anything you are not trained to do. Downed electrical lines are a very common hazard of vehicle crash scenes, so never attempt to pick it up and move it. I don't care if they say everything's turned off. That is not our job. Instruct the patient to remain in the vehicle until the power is turned off. Do not get out. Stay in there. Remain in the safe zone outside of the danger hot zone. If a patient is unconscious, unresponsive, and they have down electrical lines across the vehicle, it does not matter their condition. You cannot go approach that vehicle until the power is turned off, or else we'll have two patients. So the hot zone is the area where individuals can be exposed to sharp metal edges, broken glass, and toxic substance, radiation, or explosion of a hazardous material. And I'll show you guys here the next photo. Right? Keep a distance. Now, if it's a hazmat release, let the hazmat teams and people that are trained in hazmat come up with isolation distance areas. Okay, it's not our job to do that. EMS does, in a hazmat situation, does not work in the hot zone or the warm zone. Hot zone is where all the techs go to do their thing. A warm zone is where decontamination happens. And a cold zone is where the public stands. Incident command is usually there. and that's where EMS stands. And they bring us the patient after they've been deconned. Family members and bystanders will also create hazards as well. They want to help. They want to make sure they can get in, and a lot of times they are just in the way. They may need to step back and move. Automobile on its side or roof can definitely be a danger. It can roll on you if it's on its side. On the roof, it can slide down hills. Remember, you have fuel spilling out of areas as well. So rescue personnel have to come in and stabilize the car. Once they say it's stabilized or the car is in park, brakes set, ignition is turned off, keys are removed, or if it's an electric vehicle, the key is removed away from the vehicle more than 100 feet. Both battery cables should be disconnected to minimize the possibility of sparks or fire as well. Alternative fuel vehicles. Now, there are other ones that are out there. We have obviously hybrid systems. We have fully electric systems. We even have vehicles that run directly off propane as well. Remember that in alternative fuel vehicles, there may be more than one battery, or there could be a high voltage system like the hybrid cars. This can take up to 10 minutes to de-energize after the main battery is turned off. There's still power in the system. So avoid any kind of high voltage cable. Typically they're orange and their components as well. Fire in extrication classes, we teach you how to remove or disconnect the high system. There's EMS emergency, or should I say fire emergency disconnect devices within the car. There's one spot in the car that disengages the high system. If you smell an unusual odor, don't go near the vehicle. Retreat if you're experienced burning eyes or in throat. It means we have battery acids that are leaking out. Potential. Support operations include lighting of the scene, establishing tool and equipment staging areas, and marking helicopter landing zones for special support ops. Fire and rescue personnel will work together on these functions to kind of make a landing zone if need be, or set up on tarps and things like that. The critical phase of extrication, make sure that the vehicle is stable, hazards are eliminated or controlled. We're going to check for the incident commander, and enter only after these conditions are met. We do not go in until the vehicle is stable and safe enough for us to go inside. We want to identify the safest, most efficient way to gain access, at least to get us in. And then the extrication team will then make determination of how the patient's going to get out based on your assessment of the patient and how fast they need to be removed from the vehicle. So one thing about gaining access, always try before you pry. As fun as it is to pick up a set of tools and cut a car, if you can open the door manually, let's do it.
That's even like the same way with people's houses. Make sure you try before you pry.
Yes, please do that. Please do not break down doors if they're unlocked, or if they have a window you can crawl through. Jeff, I also saw that you posted Eastern Propane trucks are running off their propane. The old Schwann's trucks used to be propane fed as well. So there's other alternative fuels.
Some of them still do. I see them still filling up some of their trucks with propane.
Yep. So to determine the exact location and position of the patient, consider the patient, is the patient in the vehicle or in some other structure? Is the vehicle or structure damaged? What hazards exist? What poses a risk? In what position is the vehicle? Is it on its side? Is it on its roof? Is it standing end on end? Is it hanging off a guide wire? What's going on? So gaining access as patients, conditions do change. You may have to change your course of action. We're going to provide rapid extrication to patients unresponsive, altered mental status, certain like pelvic fractures, femur fractures, things that can cause significant internal bleeding. CPR is not effective if the patient's sitting up. Now, if it's all you can do, then do it, but we need to get them out. You may have to move a patient into a supine position on a longboard potential as well. And if the team of experienced EMTs should be able to perform rapid extrication in 1 minute or less. But again, depending on stability of the vehicle and how we work. Keeping the patient safe, a heavy fire-resistant blanket can protect the patient from breaking glass, flying particles, tools, and hazards. Cover your patient, right? If you don't have a fire-resistant blanket, then a blanket works. Just cover them up. The long backboard may also be used as a shield as well, and will also have to be utilized to remove the patient out from the vehicle. All right, so we talk about longboards. We don't use them anymore. We don't even test on them anymore. But they're still an extrication tool that can be very useful. You want to keep the heat, noise, and force to a minimum. They do not rock the vehicles as you're trying to stabilize. So what would you think would be wrong with this patient here?
Head injury.
Head injury. What gives you that indication?
Mitering of the windshield.
Perfect.
Spider glass.
Exactly. Look for the spider glass. So try to access the patient as quickly and simply as possible without utilizing tools or breaking glass. Cars are built for easy entry and exit. They are. Until they're damaged. All right. The rescue team should provide access. What are we starting to see more of now with windows? Are they still tempered glass? What are we starting to see now around vehicles? What type of glass now? All around. Anybody?
I have no idea. I haven't broke into a car in a while.
I'm a little confused about the question.
Laminated glass. So tempered glass is not going to be seen much more in the newer vehicles now. We're seeing laminated glass and safety glass, which is great for a patient because it protects them from broken glass as they roll a vehicle over and get into an accident, but it makes it difficult for fire and EMS to gain access. So they're making the vehicle safer for the patient, more difficult for us. Keep that in mind. You may not just be able to break windows anymore. So sad. Use all the door handles to roll down the windows before using other methods. So before you disconnect the battery, move your electric seats first. Put down your windows first. Right? Then disconnect the battery. Please do not cut cables. Okay? Try to just disconnect them if you can. You may have to reconnect them to move something. Complex access requires tools. Hydraulic, hand tools, pneumatic, and nowadays, battery. So this requires special training and to meet level of expertise. As you can see here, you're seeing this tool here we're looking at. These are called spreaders. I don't know if there's anything else in there. I really can't tell. This looks like a hydraulic device. All right. So perform a primary assessment, provide care before further extrication or extraction. Manual stabilization, put a C-collar on. Open the airway, high flow oxygen. Make sure they have adequate ventilation. Control any significant external bleeding. All critical injuries, treat them as best you possibly can. Any hemorrhage control, tourniquet, right? So work with this. Take everything you've learned through trauma assessment and management and apply it to these patients. Coordinate rescue personnel to determine the best route of removal, right? You may have people that do extrication on fire departments that are not EMS, that have no idea about patient care. You've got to tell them the best way to get this patient out. Pelvic injuries, take the roof off and take them out straight, right? Turning them can cause more issues. Now, vehicles on fire, rip them out, right? Patients in cardiac arrest, at that point, doesn't matter if their pelvis was fractured, their heart's not beating, get them out. You got to make that determination on your own on what you're going to do. So vehicle extrication techniques for complex access would be brake and gas pedal displacement, dash rolls, door removals, roof opening and removal, seat displacement, steering column displacement, and steering wheel cutting. Don't cut the steering wheel anymore. That's too dangerous. Okay, there's other methods of moving them. Just roll the dash, it's easier. Your patient should participate in the preparation. Your patient, wow. You should participate in the preparation for patient removal. You want to determine the urgency of extrication. You, as a EMT, need to determine on your general impression, is this patient sick or not sick? And if they are sick and it needs to be a rapid extrication, you have to relay that to the extrication team. They know this is a priority patient that has to get out now. Your input is essential so that the rescue team plans an extrication that protects the patient from further harm. Let them know what's going on. You have to communicate. Impractical to apply extremity splints within the vehicle. You can't. It's not going to happen. You cannot put on a traction splint for a mid-shaft femur fracture while you're in a vehicle. They have to be extricated out. Right? We can't place pelvic binders on a patient who's in a sitting position. They have to be lying down. So you have to let the extrication team know, this is my situation. This is the impact that we had. My mechanism and index of suspicion shows this. They have pain here. The best removal is going to be taking them straight out through the roof. Do your thing. They go in there, they do the thing. Perform a complete primary assessment once the patient is free. Head to toe assessment rapid, right? 60 to 90 seconds. Collar if it's not already done. The first thing you should do in a motor vehicle accident is put a collar on a patient. Stabilize that neck. They're going to want to turn, look, and see what's going on, so stabilize it. Move the patient in a series of smooth, slow, controlled steps with designated stops. All right? If the patient has a cervical injury or a thoracic injury, we don't want to start twisting and turning and poking and prodding to get this patient out. Slow movements, unless they are critical, and that's when things start to change. One person should be in charge. We don't want 15 chiefs running the show. One person has to be in charge of patient movement and care, and that person has to give out orders on what needs to happen. Ensure that everyone understands the steps, okay? Make sure everybody knows what they're doing, because if one person does something wrong and drops a patient or doesn't hold the board right or they don't hold C-spine correctly, then bad things can happen. Remove the patient as a unit, as one unified team, and protect the patient from hazards, as you can see here. You have to work together as a team. Termination involves returning emergency units back to service. Make sure you go through all your equipment, complete your reports, make sure everything's back in service, and clean it. Do not just toss stuff back in cabinets. Do not just take your extrication tools and throw them back inside without cleaning them, making sure they're ready to go. Go through everything, refuel stuff, clean your ambulance, clean your trucks, please, because this is going to help. This is going to help for the next extrication that you have. All right, so some other specialized rescue situations. Cave rescue, confined space, cross field and trail rescue like park rangers, dive rescue. Again, missing person, mine rescue, mountain rescue, ski slope, cross-country ski, snow, ski patrol, structural collapse. There's all these different types. Special weapons and tactics, SWAT team stuff. Technical rescue, ropes, trench, water, small craft, whitewater rescue, swiftwater, ice rescue. There's all these different ones that are out there. And the thing is, if you're not trained to do it, then you can't provide that type of care. All right. So again, you need to be up to speed on what else is out there. And if you want to get educated in it, then take a class. It's great stuff. Personnel need special technical skills and equipment to meet NFPA standards. Remember, these things may contain hidden dangers. So if you do not know the hidden dangers of water rescue, you probably shouldn't be going out and performing a rescue. A rescue group is trained and on call for certain types of technical rescues made up of individuals from one or more departments at times. They have county-based teams, or they have a specific department. Many members are also trained as an EMT. NFPA 1006, if you follow it to a T, requires you to be, if you're a technician level certification, you have to be an EMT as well. So Not a lot of departments follow that because they can't. Many people on volunteer departments or on call situations want to be EMTs, but they know how to cut a car. They know how to take care of a trench. So again, they may not be. Check with the incident commander to see if the technical rescue group has been summoned. Right? Do not start playing hero and going in to do a job you are not trained to do so. The lack of identifiable leadership also hinders rescue efforts. If there is no incident commander present, follow local guidelines. Somebody has to be in charge of the entire scene. Someone has to establish that command. So when you arrive, you'll be directed or led to a staging area. Bring your equipment that you're going to need to get that patient removed. An ambulance is usually summoned to the command post when a person is lost outdoors or a search effort is initiated. Your role is to stand by the command post until the missing person or persons are found. We're an ambulance crew. We're not search and rescue. They bring the patient to us. You may be asked to stay with the family of the lost individual. It's not a bad thing, because now you can start getting information about the lost individual, like medical history, your sample, and things like that. So use them. Set your radio to a discrete volume as well. The last thing you want is to say that you found the patient and they're dead on arrival. All right. Keep it low enough so they can't really hear, but you can hear what's going on as well. All right. Let's see. So once the missing person is found, you will be guided by the search personnel to the location where you can begin treatment. They're not going to make us walk in miles in. What you're going to do is they'll probably put you on a UTV, Sobulance, some kind of device to get you out to the patient so you can start treatment. Trench rescue, many cave-ins and trench collapses have poor outcomes for victims. A lot of weight, suffocation. Collapses usually involve large areas of falling dirt that weigh approximately 100 pounds per cubic foot. This will actually crush a patient and will not allow them to fully expand their lungs, and they become hypoxic, and then they go into respiratory arrest, and then turns into cardiac arrest. Trench rescues are very slow, and they have to be done appropriately. If not, then it will collapse onto you itself as well. The risk of secondary collapse is definitely a concern, so safety measures have to be done. Vehicle responses have to be at least 500 feet from the scene. We don't want to cause any more secondary collapse. All vehicles should be turned off, and road traffic should be diverted from the 500-foot radius. We never approach any kind of trench until we start putting plywood down to distribute our weight, and or like 2x12s and things like that, planks that we can walk on to distribute our weight so we don't put concentrated load down. There's a lot of other things that are utilized for trench rescue, including whether you use air shores or struts. You have to have a lot of plywood, 3/4 inch or 1 inch plywood, low pressure airbags to fill void spaces. There's a lot behind a trench rescue. So again, these things here take a while. So talk to witnesses and things like that. Assist non-trapped individuals from the area and do not enter a trench deeper than 4 feet without proper shoring in place. The deeper you go, the higher chance you're also going to lose oxygen. This is why they have vents that go inside to help you breathe 21% oxygen versus 19 or 18 or 17, where your body can become hypoxic quickly. SWAT team or tactical or TECC stuff, tactical medicine. SWAT team, sometimes if you're a paramedic, they can also employ you to be a SWAT medic that goes in with the team. These are used for snipers, barricaded subjects, or hostage incidents. If you're not part of a SWAT team medic or EMT or nurse as part of the team itself, they'll have you stage away, and then they'll have you come in if they end up getting the victim, and or they take down the person that's doing all the harm. So when called to the scene, determine the location of the command post and report to the incident commander. As you approach, lights and sirens should be turned off so you don't indicate where you're located. And also startle the person that's inside as well. The command post is usually located in an area that cannot be seen by the suspect and is out of the range of possible gunfire. This is where we want to be. So as far as planning measures, they are key to have incident commander identify the specific location. The incident commander should then determine if a safe location to meet up with a SWAT team if an injury does occur. Helicopter landing zones, just in case we have shootings, and then also the quickest route to the closest hospital, burn center, or trauma center. And finishing up here, a couple things about structure fires. In most areas, an ambulance is dispatched with a fire department apparatus for a house fire, whatever it may be. Our job is to provide firefighter rehab and also provide patient transport as needed. We are not fighting fire as EMS. So we're going to be asked to stage far enough away from the fire to be safe, but we also have to make sure that we're not blocked, right? So that we can transport out if necessary. Search and rescue in a burning building requires specialty training and equipment using SCBAs and turnout gear. Now, if we have a firefighter that goes down, we need to be familiar with EMS and how air packs and fire gear work and how to take them off of patients, right? That comes out. But we stay in the ambulance until otherwise instructed. If the patient is burned, they bring them to us. We do not go anywhere near the burning building. And we also provide firefighter rehab. And to finish up, sometimes the scene may be further complicated by a hazmat. If that's the case, as well as a much larger area of population, then we're going to be standing back far enough into a upwind, uphill situation where we're not going to be put into a what they call an IDLH environment, which is immediately dangerous to life and health. All right. So to finish up, not too bad for timing. The proper protective equipment will vary depending on the hazards encountered. Which piece of equipment should be utilized for all patient contacts? All patient contacts. Very good. C it is, gloves. Number 2, what is the first phase of extrication? What's our first?
C.
Our first phase is going to be, I only see like one person answer. Correct answer is B. There are 10 phases. The first one is preparing for an incident. Number 3, as you approach an unconscious patient who is still in her wrecked vehicle, you note that there is a power line entangled in the wreckage of the vehicle. You should do what?
A.
A.
Perfect. A it is. Number 4, a 2-door passenger car struck a tree while driving approximately 50 miles per hour. The doors are badly damaged and jammed. The driver appears to be unconscious inside the vehicle. Entering the vehicle by breaking the back window is an example of what type of access? Can I give you a little bit of an answer there? If you break the window. So breaking a window is complex access. So the answer is B. Simple access is opening the door and rolling the window down. If you have to start breaking something or cutting something, it's considered complex. Number 5, a 30-year-old semi-conscious man is pinned in the steering wheel of his badly wrecked vehicle. Once access has been gained to the patient, the EMT should do what?
C or D? D.
So the correct answer is C. Perform a primary assessment and provide emergency care needed to extricate. Number 6, while the EMT is in a vehicle assessing a patient, the rescue team should be doing what?
B.
The correct answer here is actually going to be A. So assessing A.
Yeah.
Yeah, assessing exactly how the patient is trapped and determining the safest way to extricate. We need to work together as a team, though. Number 7, proper removal of a critically injured patient from an automobile involves what?
D.
I'm gonna guess C.
Yep. C it is. Moving the patient in a smooth, slow, controlled step. Even though they're critical, unless there is a fire or anything else, we have to do a rapid. We still want to make sure we move them slow, smooth, and controlled because it could cause further harm. Bringing them out. Number 8, a man has been sucked inside of a bin of grain in a grain silo and is trapped. Which of the following rescue teams is most appropriate to request?
B. D.
Yep. Yeah, D it is. Confined space. We don't mess with grain silos. That's a confined space team. You also have to be careful of silo gases and things like that too, as well. That can drop people very quickly. Number 9, you respond to a wooded area to help search for a child who's been missing for approximately 24 hours. Which of the following equipment should you leave in the ambulance?
Backboard?
Yeah, the backboard. I'm not going to carry that around all day. Number 10, you are dispatched to the scene of a trench collapse. Upon arrival to the scene, the ambulance should be parked at least how many feet away from the incident?
B.
Yeah, I was gonna say B.
Yep, B it is. All right. So let's see. Stop recording here.